Thank you all for joining us here this morning. I'm Steve Morrison, Senior Vice President at CSIS, where I direct our Global Health Policy Center work. Congratulations to our world champion nationals. We've made the District of Columbia the capital of baseball. And happy Halloween. I don't see any costumes, though. My hopes were up. And congratulations to Janet Fleischman and all of those who worked with her in putting out this fabulous report. Much of our discussion over the course of today is really centered on the core ideas and proposals contained in that. I want to offer special thanks to Samantha Stroman, Anna Carroll, for all of the prodigious work that they've put into organizing today's event. I want to also offer special thanks to Andy Friestedt, Help staff, who works for Senator Murray, who's been so diligent and helpful and supportive in putting today together, and Janelle Krishnamurthy from Merck's staff, who has been very supportive here today. I will now welcome Julie Gerberding, Executive Vice President and Chief Patient Officer at Merck and co-chair of our CSIS Commission on Strengthening America's Health Security. Julie, welcome. Thank you so much for all the work you've invested in our Commission's activities over the last year and a half, and it's great to have you here.
Thank you so much. I really welcome all of you. The Commission is really taking on some important work, and many of you have contributed to that. I think what we've accomplished in the past year is remarkable, but this piece of work that you're going to hear more about today is kind of a keystone of the broadening effort to really focus on global health security. Before I start, I'd like to acknowledge the contributions of Congresswoman Brooks and Congressman Barra. They'll be joining you later today, but they've been active participants in the Commission as well, and we really appreciate their leadership. So you're going to hear from a number of experts today, people who really are involved in legislation, in implementation, and really working across a number of different kinds of partnerships to advance the status of women and girls, particularly in disordered states and crises. In a few minutes, I will also have the distinct pleasure of introducing Senator Murray. But before I do that, I wanted to just say a few words about why we are taking this on in the context of global health security, because this isn't an agenda that people normally include when they're thinking about health security issues. When you really step back and think about the frontline impact of global health crises, it's very often the most vulnerable people who suffer the most. People who were vulnerable before the crisis are even more involved as the crisis progresses, and we're certainly seeing that in the DRC right now in the context of the tragic Ebola outbreak in the eastern areas. These humanitarian crises often occur in fragile states where the systems are not adequate to provide support for the affected people, and often in fragile states where the government itself is inadequate to meet the needs of particularly women and children. So in that environment, atrocities occur. And we are seeing examples of that again in the eastern DRC, but in many places around the world as we sit here today. So the Commission put a big focus on how do we handle the requirements for women's health, maternal health, and child health in these kinds of situations. Situations that often are exacerbated by gender-based violence and other intense discrimination. In addition, just maintaining the normal processes of care, immunizations, safe delivery, these systems are the first to fall when the larger crisis is in play. So today, we are very pleased to be releasing this report. I think you all have a copy of it. How can we better reach women and girls in crisis? And really our aim here is to try to shine a bright light on this very, very fragile situation and raise the awareness, but also the action, the call to action, and making sure that we include this dimension in our overall approach to global health security. So the report proposes an approach that assures that the U.S. government has investments in capacities in the areas of maternal health, reproductive health, family planning, and gender-based violence, and then details how we might go about operationalizing those recommendations in this context. So I think this is a giant step forward conceptually. I hope you all agree that this is an unmet need in the context of global health security. And we have with us today a woman who is an incredible champion of women and girls in the broader context of all of the important legislative efforts that she's undertaken. Senator Patty Murray is an amazing senator, very senior in our government for those who don't know her personally. But when you go back and read her legislative record, not just the mom in tennis shoes issue, but the fact that this is a person who stood strong on the very values that make us great as Americans, but also consistently focus on the most vulnerable people in our society. So I think it's natural that she would be participating in the commission. She's going to give our morning keynote, especially commenting on the effects of disorder on families. But just keep in mind that she is a passionate champion of women in all walks of life, and I feel very, very honored to have the privilege of introducing her. Thank you, Senator Murray.
Well, good morning, and thank you, Julie, so much. It is just an honor to work with you, and thank you to CSIS for putting this event together and making sure that this commission gives the health and safety of women and girls the serious, sustained attention that it deserves, because all of us know that when disaster strikes, women often bear the brunt of the burden. Like in the DRC that Julie just talked about, where the ongoing Ebola epidemic is disproportionately now impacting women who are at greater risk because they are more likely to be the caregivers or to stay home with a sick child or to care for an ailing grandparent. And one study found that the fatality rate for pregnant women with Ebola is around 90%. So I am especially eager to learn more about the impact of the very promising treatments that we now are being deployed in the DRC on not only all Ebola patients, but that population in particular. Even for pregnant women or mothers and infants who survive Ebola, the hardship continues. One survivor described how after she and her baby recovered, people in her community still kept their distance, still refused to hold their baby because of the fear and stigma surrounding that disease. And Ebola isn't the only healthcare crisis in the DRC. Every year, malaria strikes and kills tens of thousands of people in the country, mostly pregnant women and young children. And it's not just diseases that are a threat to women's health and security. There's also an epidemic, as we all know, of gender-based violence in the DRC. In his Nobel Peace Prize lecture last year, Dr. Denis Mukwege gave a chilling account of the sexual violence that is committed against women and girls and infants in the DRC. In 1999, he founded Pansy Hospital to provide care focused on the needs of survivors of sexual assault. And today, that hospital has treated over 85,000 women and girls, providing survivors gynecological care, psychological care, legal assistance, and ultimately helping them to re-enter their communities and make ends meet. And Pansy Hospital isn't the only model that shows how strong investments in healthcare for women and girls can make a real difference in their lives. Across the globe, areas affected by crisis account for almost half of all newborn deaths and 3/5 of all preventable maternal deaths. But not in Jordan, at the Za'atari refugee camp. In that dusty, crowded camp, housing tens of thousands of families, the UN Population Fund is approaching a remarkable milestone that have delivered almost 12,000 babies in the camp without a single maternal death. And in doing so, they have delivered an important reminder of what is possible when we focus on families and invest in their well-being, and what's at risk when the United States steps away from leadership on the global stage. While the United States provided most of the startup costs to open the Za'atari camp, the Trump administration has since cut our support for the UN Population Fund. And it's not just financial instability that can put care providers at risk. When fighting broke out after President Trump's sudden and I think shameful decision to abandon our Kurdish allies, one of the losses was a maternity care facility run by the UN Population Fund, which served 40,000 patients before it was damaged in the aftermath and forced to shut down. Tragically, we are seeing in real time now how crisis and disorder put women's health and safety in jeopardy. We have got to do better for women and girls around the world. When we plan for disaster, we need to make sure the needs of women and girls are prioritized from the start, not tacked on as an afterthought. We need to make sure our approach to global health security supports communities plagued not just by acute illness, but plagued by gender-based violence or by a lack of basic health care, including immunization, maternity care, and family planning services. We need to make sure our decisions are based on sound science, and medical experts are not gagged by ideology. And like Dr. Mukwege and Pansy Hospital, we need to make sure our plan doesn't just treat disease and disorder, but also treats fear and trauma. We must not only keep people healthy, we need to help them feel secure and hopeful for their future. And we know that doing this work with a focus on women and girls can have an outsized impact in addressing crises. Perhaps more striking than the fact that so many of the Ebola victims in the DRC are women is the fact that so many of the survivors now, women who are now immune to the disease, have turned around and joined the frontline efforts to care for others and stop this outbreak. Women across the world are going above and beyond to provide stability to their own communities, as they always do, to keep their families healthy and safe. It is time that we make sure that our strategies for global health security prioritize doing the same for them. I'm very proud of this commission in their part in this effort, and I know that the rest of today's event will continue to move this important conversation forward. So I personally want to thank you all for being here, for being a part of it, for raising your voices for women around the globe. Thank you so much.
Thank you, Senator Murray, for those remarks and for being such a champion for women and girls around the world, as well as here at home. And thank you also to Senator Murray's staff for all their help and support in the course of this project. And special thanks again to Samantha Stroman and Anna Carroll and to Steve Morrison, who has directed this program, and for so many of you in the audience who have been supportive and whose input has been crucial for us to help craft this in a way that could be concrete and impactful. So thank you all for your engagement on these issues. My name is Janet Fleischman. I'm a senior associate at the CSIS Global Health Policy Center. And just picking up on what Senator Murray was saying about Dr. Denis Mukwege and the Panzi Hospital. As you remember, last year, Dr. Mukwege and Nadia Murad won the Nobel Peace Prize to honor survivors of rape and war and those who assist them. And I think it's worth recalling what Denis Mukwege said in his Nobel acceptance speech that relates to the subject of today's discussion. He said, "The aim of these rapes, used as a weapon of war, is to destroy the victim, her family, and her community. In short, to destroy the social fabric." That's why GBV, gender-based violence, matters to health security and to building resilience. Women and girls are key actors in humanitarian and crisis responses, but they are often targeted as weapons, as a weapon of war to undermine communities' resiliency and health security. Gender-based violence is ubiquitous, often hidden, and gravely underreported in crisis settings, with profound consequences for women's and girls' physical and mental health, safety, and empowerment. The magnitude of this problem is stark. It's estimated that 1 in 5 women and girls who are internally displaced or refugees experience gender-based violence. In 2019, 34 million women and girls of reproductive age are estimated to be in emergency situations, often explicitly targeted with sexual and gender-based violence as a tactic of war, designed to traumatize and silence women and undermine their communities. We know that GBV comes in many forms, including rape, sexual exploitation and abuse, intimate partner violence, forced and early marriage, sexual slavery, emotional and psychological abuse, and we'll be hearing more about that from our panelists today. Adolescent girls are particularly vulnerable to increases in GBV after conflict and displacement. It's also important to note that men and boys also suffer from such abuses. Survivors of sexual violence have critical needs for protection, physical and reproductive health, mental health, legal assistance, social and economic reintegration, and stigma reduction. All of this impacts the physical and emotional well-being of these women and girls, their families, and their communities. So we are going to hear today from 3 leading voices who are working on gender-based violence in humanitarian and fragile settings from different perspectives. You have their full bios, so I won't read them out, but we are going to begin by hearing from Lisa Carty from OCHA, who will provide a multilateral perspective on new efforts and enduring challenges to address GBV responses in crisis. Then we'll hear from Fatima Imam, who has traveled here from Borno State in northeast Nigeria and works on reintegrating survivors of gender-based violence, particularly those who were abducted and abused by Boko Haram. Fatima will frame this panel with an on-the-ground perspective of the impact of GBV on women and girls and on their communities. And finally, we'll hear from Sheba Crocker from CARE to get the view of an implementing organization about promising practices around the world, how to keep survivors at the center of the response, and how to influence donors, especially the United States. We'll then have a short, moderated question and answer period before opening it up to questions from all of you. So let me turn the floor to Lisa Carty, and thank you all for being here.
Thank you very much, Janet, and congratulations on the event and on the amazing paper. And let me just say what an honor it is to be here and to be on a panel with Sheba, who I've known for many years, and I'm a great admirer of CARE's work. They've been such a leader on these issues. They're a very important partner of OCHA. And with Fatima, who I had the pleasure of meeting last May for the first time at a conference that I'll say a little something about. But Fatima is such an eloquent and thoughtful spokesperson on these issues. We're really privileged to have her with us as well. So Janet asked me to actually address 2 things. First, to do a little bit of sort of a scene setter of the global humanitarian trends that pertain to this particular issue, and then to say a little bit about what the multilateral system can possibly do to help advance the agenda. So the very sad fact is that gender-based violence often presents itself most acutely in humanitarian crises where perpetrators are rarely brought to justice. Unfortunately, the scale and complexity of these crises is growing almost exponentially. By some estimates that I've heard recently, 12% of the world's population today live in crises-affected countries. Today, that means we have an estimated 150 million people in need of humanitarian assistance in 58 different countries. That's almost double the number of people in need 5 years ago. If we assume that half of that figure, or 75 million people, are women and girls, and if we combine that with the fact, as Janet mentioned, that 1 in 5 displaced women who are asked say that they've experienced some form of sexual violence, the dimensions of this problem become absolutely staggering. And importantly, less than 1% of global humanitarian funding is spent on GBV, despite the absolute acute need. So how can the multilateral system help drive faster progress? Let me quickly highlight 3 areas. I think the first is in setting norms and standards and creating very high expectations for what we can achieve. In 2017, the normative body that helps guide humanitarian programs, something called the Interagency Standing Committee, introduced a policy and accountability framework on women and girls in humanitarian action. It's significant because for the first time, it sets specific targets across a range of practical actions, including things like ensuring that a gender analysis informs all program planning. It's intended to help guide the development of individual country humanitarian response plans. These plans are developed every year in the 30-plus most crises-affected countries, and this is a process that my own organization, OCHA, helps oversee and coordinate. Our goal is for these country plans to be ever more sensitive to a range of gender-related concerns, but we have a particular focus on GBV response strategies. In implementing this approach, we've relied heavily on the guidance provided in the call to action, in particular in something called the GBV Accountability Framework, which some of you might be familiar with. The framework is actually a very practical tool that outlines a range of considerations, from the importance of using gender and age disaggregated data to the imperative of having women at the table as partners in all aspects of program planning and implementation. We're making progress in getting this analysis embedded in all our country planning, but we still have quite a lot of work to do. The second thing the multilateral system can do is model best practices through our funding channels. For example, OCHA manages the UN's emergency pool funds, which disperse about $1.5 billion a year in funding. We've made a commitment to step up their support to GBV programming, and the commitment is deep and is shared by my colleagues in the field who manage these funds on a day-to-day basis. In Yemen, these funds have supported the creation of GBV safe spaces and prioritized women's leadership in project design and management. In Syria, there's been an emphasis on vocational training and livelihood programs as GBV risk mitigation measures, as well as the establishment of mobile teams to do outreach and case management. Significantly, a woman representative of a Syrian NGO now sits on the advisory board that helps manage these funds. In South Sudan, an innovative program operated in conjunction with CARE trains women in the production and use of fuel-efficient cook stoves to help decrease their exposure to GBV if they need to go out every day and try to find firewood. Each of these efforts was based on extensive community engagement and consultation, and there are many other examples, but the intention is to scale all of these up more broadly. The third area where I think the multilateral system can help drive change is through its ability to leverage high-level political leadership, advocacy, and resources. We saw this in Oslo, Norway last May, where OCHA, along with the Norwegian Prime Minister, organized the first ever donor conference on ending sexual and gender-based violence in humanitarian crises. And please note the level of ambition in that title. It was on ending GBV. The conference, while just one event, was notable on a number of levels, and Fatima was there and might want to say something about it as well. It raised $363 million, which of course is helpful but not sufficient. But for me, what was most significant was that it was grounded in the voices of those who understand the problem best, in the voices of survivors and in the voices of almost 170 local NGOs and 76 international NGOs that attended. And very importantly, there was agreement on a follow-up accountability mechanism to help ensure that pledges are being realized. While Oslo is one example, there are others, including the now regular inclusion of women's organizations in major UN humanitarian pledging conferences. And we can keep doing a lot more to ensure that those closest to the problem are helping drive the solutions. So just to wrap up, let me say a few words on where we should be investing even greater energy and resources. First, I think we need better data so that we can keep making the case ever more effectively. We need better data on the dimensions of the problem, the number of women and girls affected, and men and boys, but also on our ability to track financial flows and investments in GBV programs. Second, we have to remember that accountability matters at every level. So in the system I work in, we need to be asking ourselves as UN staff, how do we deliver on our commitments? And more broadly, how do we ensure that donors and governments are living up to their promises? And most critically, how do we ensure that perpetrators are brought to justice? Third, we need to change our level of ambition and our mindset. We need to think about gender-related programs, such as GBV programs, as core life-saving interventions and not as something we do that's additional. And as we do that, we need to ensure that those closest to the issue, and here I'm referring to women's organizations, are in the lead. And finally, of course, we always need to be mindful of the cost of not acting. That comes back to why it's so important to have this event here in Washington framed around the issue of advancing health security. Because the truth is that all the statistics don't capture either the human cost or the societal cost of GBV. We know that societies rebound faster from crises when women lead and when they are fully engaged and their needs are met. If we want that to happen, if we want the many societies that are today in crises to start to recover and move forward, then we really need to be paying a lot more attention to how we prevent and mitigate the impact of GBV. Thank you.
Thank you, Lisa. We're going to turn now to Fatima.
Am I on?
Yes.
Okay. Thank you, Janet. Good morning, everyone. I would like to begin by thanking the organizers of this program for inviting me to come here. Since I came, I've had people thanking me for coming far, but I really appreciate the opportunity to come and give a voice to thousands of women and girls that are affected by this insurgency, women and girls whose voices would otherwise not be heard. So it's not about me. I would like to start by sharing with you all the story of Amina, one of the women, girls that I met in the IDP camps during my routine visits. Amina was abducted by Boko Haram when she was 12. She was abducted as a girl, but she returned as a woman. She was married multiple times, 5 times to be precise, to different men. Amina returned with 2 children, pregnant and infected with HIV. Both of her children are also infected by the disease. This story is not peculiar only to Amina. This is what thousands of women experience in northeastern Nigeria as a result of the ongoing insurgency perpetrated by Jama'atul Ahlul Sunnah lil Da'awati wal Jihad, otherwise known as Boko Haram. Women and girls are actually the face of the crisis in northeastern Nigeria. However, their voices and agency remain silent. Women have borne the brunt of the insurgency over a period of 10 years in camps, in IDP camps, in the communities where they live, and within the humanitarian settings perpetrated by Boko Haram. As we all are aware, because of the insurgency, there is massive displacement of women and children from the communities into Maiduguri metropolitan, that is the capital city of Borno State, where in IDP camps, most of these women and girls become heads of households. They become very exposed to physical and sexual abuse. They are at high risk of such abuse and more likely to experience rape, sexual exploitation and abuse, and they engage in other coping mechanisms just to survive, for them to be able to access food, for them to be able to access shelter and other NFIs within the camp settings. For GBV perpetrated by Boko Haram, we all know that abduction has become a trend for Boko Haram against women and girls. That can be seen in the multiple and forced marriages that women and girls go through, the rape, forced labor, and slavery. Most of these women return pregnant infected with diseases, trying to reintegrate into communities who actually stigmatize and discriminate against them and the children that they bring back from captivity. That becomes highly traumatizing and stigmatizing for these women. It causes a lot of them to actually be in isolation. That experience of these women actually has a lot of health implications. Like I mentioned, these women return infected with a lot of STIs, STDs, like fistula, like HIV and AIDS, and with the overstretched health facilities that exist in northeastern Nigeria, the fate of people like Amina can better be imagined. Also to mention that is deliberate on the part of Boko Haram. The targeting of women and girls is not just strategic, it is also deliberate because they recognize the role of women as agents of change. They also understand that there's a saying, if you educate a man, you educate an individual. But if you educate a woman, you educate a community or you educate a nation. So that is deliberate in attacking communities to deliberately undermine resilience of those communities. When you target the education of a community, that means you're ensuring that that community continues in a circle of poverty, of underdevelopment, and that also leads to the women being more vulnerable and further marginalized. I would like to say that the socioeconomic condition of women and girls in northeastern Nigeria continue to worsen by the day. And if we collectively as actors, international community, donors, local civil society organizations, and the rest do not tackle this issue, then it means that the circle of poverty, marginalization, and deprivation continues for these women, even beyond the insurgency. So I would like to stop here and hope to continue later. Thank you very much.
Thank you, Fatima, as always, bringing this on-the-ground perspective and pushing us to think in ways that perhaps we are not doing enough here. So we'll get to more of that in the Q&A. I'm going to turn now to Sheba Crocker from CARE.
Thank you, and thanks very much to CSIS for bringing us all together, and congratulations also on this really important report. And I mean, I was thinking as we were all talking that this is also a sort of a good lineup of how we're going, hopefully, about this panel. So I'll try to plug in some of the places I think where it will be evident the kind of perspective that an organization like CARE needs to have to try to address these issues in the way that we have been for decades now. And, you know, we've had a lot of the sort of global snapshot, so I think just three things that I would highlight in addition to what Janet and Lisa helpfully put on the table. I think one is we're currently seeing unprecedented levels of awareness and mobilization globally, yet even as global commitment and the evidence of what works grows, progress remains elusive for women and girls in many parts of the world, and particularly in those parts of the world impacted by conflict and humanitarian crisis. Second is that GBV happens everywhere without exception, including in our own organizations and programs. And third is that most of this violence is perpetrated by intimate partners. And so while I think a lot of the focus has been on the systemic violence perpetrated by non-state and other armed actors, recent research has found that even in conflict-affected settings, the prevalence rates of intimate partner violence perpetrated against women and girls are higher than rates of sexual violence by non-partners. So as we think about how CARE tries to tackle these issues, I mean, obviously, one needs to think about the root causes, which, needless to say, are multiple, but the importance of recognizing that there are multiple root causes is a really important part of thinking about how to, successfully addressing these issues. So I won't go into too much detail, but just to sort of list them off. One is that gender inequality lies at the heart of this issue. GBV is often used as a tool to dominate and to intimidate and to reinforce gender inequalities among and across groups, and I think what Fatima just put on the table really highlighted that. GBV is exacerbated in crises due to the normalization of violence and to the breakdown of the rule of law, the breakdown of social fabric, and the proliferation of arms. Displacement, migration, and separation from family support structures is also a risk factor for GBV due to increased stress or poverty, to the breakdown of social support structures, reduced oversight from family and friends. In May, CARE did some analysis on the border between Venezuela and Colombia, which we did a rapid gender assessment, which really highlighted that crisis is a crisis of gender. And when you look at especially the informal places in which women and girls are crossing the border on a daily basis, it's just hitting at sort of every stage. So whether it's human trafficking, whether it is gender-based violence, whether it is the need to resort to transactional sex for survival. It's just, it really highlighted that, and I recommend that report to everybody. Conflict obviously can increase poverty in a number of ways, which in turn increases incidence of gender-based violence. So I think, again, this is sort of the idea of this vicious cycle. So some quick thoughts on some sort of top-level thoughts on challenges and solutions. I mean, and picking up from Lisa's point, that documenting the problem of GBV is critically important, and it's difficult anywhere, but it's obviously particularly challenging in some of these settings where we're really focused today, where infrastructure and social fabric has been eroded. In humanitarian context, most reporting or most available data on gender-based violence tends to come from service delivery statistics gathered when women and girls seek health, psychosocial, or other services after an incident, but because many survivors do not seek such services, the prevalence of violence is potentially actually grossly underestimated, which is particularly frightening when you think about even the statistics that Lisa put on the table. So there's definitely a need for more research and data to better understand the scale and the nature and the prevalence of various forms of GBV. I mean, I think the good news, to the extent there is some, is that a growing body of research and evidence has begun to emerge about the prevalence, forms, and drivers of GBV in crisis settings and what is needed to respond to it. And in particular, there's some multi-year DFID-funded research that's called What Works to Prevent Violence Against Women and Girls, which CARE is a part of, and which I think some key findings have come to light, including, again, that the most prevalent form of violence experienced by women and girls is perpetrated by intimate partners. And I think it's just important to continue highlighting that, because successfully addressing this, we cannot successfully address this problem if we don't all acknowledge that. Community-based programming approaches targeting, that approaches targeting attitudes, behaviors, and social norms change has shown some promise. And the research also suggests that economic empowerment and cash transfer programs alone are unlikely to be enough to reduce long-term GBV outcomes and may, in fact, exacerbate intimate partner violence. There's a need for capacity building across humanitarian sectors in order to enable staff to identify, report, and respond to cases of GBV. It's very important that all sectors incorporate GBV risk mitigation approaches into their programming and make all humanitarian sectors safer. Addressing, because I talked a bit about the multiple drivers, addressing GBV requires a comprehensive multi-sectoral approach, and it also importantly requires us to go far beyond technical or technocratic approaches to address harmful norms, to address unequal gender relations, breakdowns in the rule of law, and other factors that drive and sustain GBV. And needless to say, as always, more funding is required to meet the scale of the need globally. So just quickly, I thought it would be useful to give a couple of specific examples of the types of programming that CARE does across different settings. We work on GBV and emergencies around the world, and we focus on a sort of comprehensive programmatic framework that brings together prevention, mitigation, risk mitigation, and response. So a few examples. In Cox's Bazar, CARE is implementing safe spaces for women and girls, and also training other staff in the camp in counseling and psychosocial support, as well as first aid and prevention. In South Sudan, CARE is using an integrated mobile response to reach hard-to-reach areas, and Lisa referenced some of our work together there, and also engaging community leaders and men and boys to change harmful norms and cultural practices. In the DRC, we're undertaking capacity building activities with local partners to operationalize the minimum initial service package for reproductive health in emergencies. Across the Great Lakes region, we are using village savings and loan groups and other forms of collective action to mobilize communities and, again, engage men and boys to tackle social norms that underpin GBV. And this work builds on a successful approach that CARE has undertaken in Rwanda, which resulted in a reduction of intimate partner violence by 55% through a combination of interventions advancing women's economic empowerment while also engaging couples and communities in dialogue and in activism to reject violence against women and girls. We also, sort of looking up from the programmatic, have made an institutional commitment to integrate GBV risk mitigation actions across all of our sectors in line with the IASC GBV guidelines that Lisa mentioned. And we are prioritizing a focus on supporting women's participation and leadership across our humanitarian work, and this is both internal to CARE and external to CARE. For international agencies like CARE, it is important to recognize that effectively advancing action on GBV requires us to tackle the gender biases and power imbalances that pervade our own organizations and the humanitarian sector more broadly. And we're also partnering with and supporting a range of women's groups and collectives in crisis-affected communities around the world. And finally, I think we can get a bit more to this in discussion, but just a few top lines on what we are hoping and encouraging the United States to do. One would be to continue the leadership role that the U.S. historically has had on this issue and the commitment to this issue, continue funding, and in particular start funding or commit to funding some of the kind of some of the ways in which we need to more broadly and from a more long-term perspective address some of these root causes and drivers, and not just the technocratic approaches. And there is a bill that is moving around called the Safe from the Start Act, which we are also encouraging Congress to get behind and to pass. So I'll stop there, but we can get into some more detail and discussion. Thank you.
Thank you to all of you. Excellent presentations and lots to dive into. I think all of you talked about this issue of data and how do we get our arms around the dimensions of gender-based violence and what are going to be useful indicators to let us know that we're actually making progress, that we're moving the dial in some way. So let's start with Lisa, if you have any thoughts about what are some of the ways that we'll know if we're making an impact.
Thanks. Thanks, Janet. And I might try to answer the question actually at two different levels. I think how would we know we're making progress? I mean, there are three things that I think would be important for us to be focusing on. The first is really making sure that everything we do really is survivor-centered. And I think that's still a perspective that isn't fully enough probably embedded in all our work. Not because people intentionally don't want to do it, but just because I think it's complicated and not that easy to do, and maybe the people who really know how to do it well, we simply don't have enough of those people around. So I think that would be number one. I think the second thing is really focusing on prevention, and very interesting, actually, Sheba, the phenomena you put on the table, which I've heard about before, about so much of this being intimate partner violence. But that's a whole other level, then, of an approach that needs to be developed. And then the third thing, I think, is just this point around accountability, which is so important, because in the, I'm not an expert on GBV, but in some of the travels I've done over the years, it's very clear to me that there's huge psychological damage to survivors when they don't see that there's any repercussions. In a conversation I was a part of last night, someone was saying that not only are people not brought to justice, often survivors need to live side by side with people who perpetrated these horrible affronts against them. So for me, those three things, survivor center, prevention, and accountability, I think are key pieces. I think the data piece is a little more complicated. My own observation, I come from the public health field, where I think actually in the public health field we're quite expert and sophisticated in how we use data, how we use household surveys, how we triangulate information. My own experience, and I don't know how Fatima and Sheba would agree, is we don't quite think about it sometimes the same way in the humanitarian sector in trying to get to the level of nuance that we need to get to really understand what's going on. So I think there's a whole body of work there about how in these very complex contexts, but even in their complexity, we can still sort of tackle, I think, this data gathering and data analysis issue a bit better.
I wonder if we could turn to you to follow up on any of your thoughts about how will we know if we're making progress, but also that important point that Lisa made about survivor-centered approaches. And what does that mean in terms of women-led organizations, responses, engagement from the start of the response? Maybe you can share with us some of your perspectives on that.
Yes. To follow up on what Lisa said, actually, I think these are very strong points that she mentioned on survivor-centeredness, on focusing on prevention, and then to also strengthen accountability. And before I go further, I think I'll just want to add a couple of more points to what she has said. What is very important is also, since most of the issues also have underlying socio-economic, social and gender norms, it's very important for us to ensure that we have the opportunity to change such norms that are discriminatory and to be very careful so we do not reinforce such discriminatory processes. And that will now tie into the point of actually engaging local actors in the design and implementation, because when you bring in programs without prior consultations, then probably in most cases you tend to reinforce some of the discriminatory practices that does exist already. And then the notion of power shift. It's very important for us to shift power from international to local if we really want to see a change and be able to assess if progress is being made or not. And then to further emphasize the role of women-led organizations in the whole leadership, but as well as in the coordination structure. Women-led organizations are actually first responders. They're always first there on the field trying to respond to issues, so it's most important that we prioritize them. We all agree that funding, for example, nationally for GBV is very low, but even at that, when there is that increment, there is nothing dedicated specifically to women-led organizations to actually enhance the work that they do, which usually reduces impact that we're supposed to get at the end of the day. But most importantly, for us to work with local actors in the community, especially women-led organizations, to strengthen their capacity as well. Because I'm happy that in the report earlier, there was mention of strengthening local actors, but we want to go ahead to say by local actors, emphasizing on women-led organizations, because it's such a male-dominated area that if we do not focus on women-led organizations, then probably they just get sidelined and put by the side. So thank you.
Sheba, would you like to add anything to this?
Yeah, I won't repeat anything because I think they're all really excellent points that I agree with. So just a couple of additional things. I mean, sustainable funding would be important. I think it's important to recognize that there is often a really deep tension between being survivor-centered and all issues around collection of data. And so, thinking through the thorny sensitivities around that, I think, is critical because we've all highlighted data in different ways, but that raises some really important challenges. I think, in different ways, I think we all also addressed this question of kind of this issue cannot be an add-on. And by that, I mean, it can't be either just like a thing that is sort of tacked on as a comma and GBV activities that are meant to be handled by some like gender people over here and are never well enough resourced, but actually that we understand that these things need to be integrated across the response, and actually that at every stage of a humanitarian response, whether it's a locally led response or an internationally driven response, there is an opportunity to mitigate risk or an opportunity to increase risk, and that every decision taken matters in that context. And we certainly saw that in another rapid gender assessment that CARE recently did on the border of the US, where one had the sense that all along the way decisions were being taken that increased risk rather than the other way around. And I think changing the power dynamics and the gender inequality points are critical. And I would just note that, one of the challenges of kind of knowing where you're making success, especially when it comes to risk mitigation, is that it's very hard to prove a negative, right? It's very hard to say, if we hadn't done X, then 15 more women would have been raped in that setting, or what have you. And there is, CARE is actually implementing a new operational partnership with UNICEF that is trying to look at this question of how you actually measure the effectiveness of risk mitigation throughout an entire program cycle to determine kind of if and to what degree implementation of GBV risk mitigation interventions actually results in better outcomes for women and girls. And the ultimate goal, hopefully, and we have other partners too, Oxfam and IOM, and others, to develop a replicable methodology for ensuring that risk mitigation interventions are actually actively making women and girls safer.
Some of what you've all alluded to is this question of integration and the siloed approach that is so often the feature of the response. And I know in discussions with Fatima, she was mentioning the lack of any integrated programs. And the impact that has for women and girls trying to seek services. So maybe to begin with you, Fatima, can you describe what you have on the ground in Borno State that might be assisted, or how that response could be improved through more of an integrated response, and what would that include?
Yes, I think one of the biggest challenges that we see on the field is the fact that I think GBV is actually mainstreamed, and in the process of mainstreaming, I think we lose it. So it's so easy for you to see that they're just operating in silos, and there's no integration of this. And I think what I have in mind, or what comes to my mind, is to have a situation where we can integrate all these services together. Probably for us to have like a center, like a one-stop center, which will be a space for us to actually improve knowledge on issues that affect women and girls. It can be, for example, improve knowledge on prevention of SGBV, on reconciliation, on building resilience, on de-radicalization, and how to handle issues of stigma and things like that. So it's going to be a one-stop center that is going to be used to actually improve knowledge on these issues that will help the community. And in that way, we try to integrate GBV into all the other available services. Otherwise, as it is now, wherever you go, it's just issues of mainstreaming gender, which is actually lost in the process that it doesn't even exist. Yeah.
Shiba, I know that CARE has done some interesting work on trying to bring these silos together, because you obviously do important work on the women's health side as well as empowerment and GBV. So perhaps you can describe a little bit about some of CARE's approaches to address this integration.
On? Okay. Yeah, I mean, I think rather than going into specific places, it might be helpful to just note that we recently adopted a new gender-based violence in emergencies framework, which includes 6 priorities, and I think does give a sense of how you need to bring so many different things together, as Fatima was just saying. First, ensure the routine inclusion, resourcing, and monitoring of gender-based violence risk mitigation measures across all programmatic sectors. So again, that's just to highlight that, whether it's food security, nutrition and livelihoods, WASH, shelter, SRH, and modalities like cash and voucher assistance and services and in-kind. Second, work with communities to change harmful social norms and address other root causes of GBV in settings of crisis. Third, establish and implement women and girls safe spaces, which I think is very aligned with what Fatima was just saying, in order to provide targeted prevention and response services, as well as needed capacity building for women and girls in humanitarian contexts. Fourth, provide appropriate gender and age-sensitive sexual and reproductive health in emergency services wherever possible. Fifth, engage men and boys to prevent and address GBV. This is an issue that predominantly impacts women and girls, but it is not a women's issue. And if we're going to tackle it, we have to understand that we need to address this at all stages and with all genders. And inform learning, adaptation, and scale up of CARE's work and advocacy to influence changes in humanitarian processes, practices, policies, and programming to address GBV in emergencies. So in other words, to understand where things are working and why, and then to try to take that to scale, as we say, in various ways, but to actually much more deeply influence from a policy programmatic perspective and otherwise, both what we're doing, but importantly, what the entire sector is doing and what donors are doing, et cetera.
So I'm going to ask one last question, though I feel we could go on all day, so that I can open it up and get questions from the audience. We have a number of high-level events on the horizon. There's 25 years after the IPCD, which many of you are going to in Nairobi in a few days. In 2020 will mark the 10th anniversary of the UN Security Resolution 1325 on women, peace, and security. The 25th anniversary of the Beijing conference will be next year, and France is hosting a major conference on Beijing Plus 25. There's the Generational Equality Forum at the high-level meeting at UNGA next September. So there's many opportunities, you would think, to highlight the issues that we're talking about today. So I guess just quickly to get all the responses from all of you, what is your message for these events and these high-level opportunities of how to prioritize gender-based violence? Let's start with Lisa.
Well, the first thing I would just quickly say is, in some ways there's not a lot of mystery here. I think we do know what to do. We just need to get on with doing a lot of it a lot better. And just a quick observation, I think process, which is a bit what you were talking about, Fatima, is really important. And we need to improve the processes, as boring as that may sound. But I think in the humanitarian sector, we have very siloed ways of planning. So until we kind of break that down and actually bring this more into the core in a cross-cutting way, I think we're just not going to be as successful as quickly as we need to be. So that would be a key message, actually, that I would like to see each of these events address, is given the knowledge base that we already have and the tools that we have and the money that we have $15, $16 billion a year going into humanitarian programming. How do we make the processes quickly start to work a lot better?
Fatima.
Mine is very simple. There is this prioritization of international actors over local actors. So I would say recognize and appreciate local actors, period.
And Sheba.
I would pick up maybe on Lisa's point that I think it's, there's an opportunity now for humanitarian actors, donors, and governments to translate the evidence and the learning that we have into action, to step up effective action on GBV, and that's where we need to be moving. All of these sort of conferences, frameworks, commitments, et cetera, have been extremely helpful, actually, in raising the spotlight and the focus on this, but now we just need to move to doing what we know needs to be done. And to pick up one other point that we've already touched on a little bit is just the opportunity to strengthen accountability for action. I think we have a good framework in place now to do that. But again, it's not, we often hold ourselves accountable in a funny way in the humanitarian sector. And it sometimes reminds me a bit of the proverbial self-licking ice cream cone. So it's very related to this question of transfer of power and how do you really make sure that we are being accountable to populations and that ultimately we are transferring power in the right kinds of ways and not accountable to ourselves only or to ourselves and a set of donors.
Well, thank you all. We're going to open it up to questions, and then we'll come back for one last lightning round of responses from the panelists. So I'm going to open it up to the floor now. Please raise your hand. We'll take a couple of questions together. Please identify yourself and keep it to one question, if you don't mind. And someone will come around with a microphone and please speak into it because we are recording this so that others can, we'll post it on the CSIS website. So thank you. We'll start over here.
Hi. Thank you so much for this. I'm Sarah Tharkin. I'm from the Congressional Research Service. I do global health and international development. My question is about research, and forgive me if you talked more about this than I recalled, but in incorporating better questions or figuring out better research tools, I'm wondering, are there any opportunities perhaps in like the demographic and health surveys or existing, you mentioned DFID, but, and I don't necessarily direct this to anyone, but if you could speak to that a little bit, because I know that's like a household survey, right? So it's better than getting these responsive questions when women are going in for services post GBV event.
Other questions?
Good morning, everyone. I'm Joan Timoney with the Women's Refugee Commission. Thinking about the theme of accountability that you all have addressed in different ways, thinking about the fact that we're on Capitol Hill, I'd be interested in hearing panelists' reflections on how donor governments can help support accountability. I mean, some of it clearly in the way that they program, but there's other ways as well through their advocacy as a leading donor. And so I'd be interested in hearing panelists' views on how leading humanitarian donor governments can support this body of work. Thank you.
One more question we'll take from the audience before we turn back to the panel.
Good morning. I'm Colonel Patrick Hickey from the Uniformed Services University, where I'm the chair of pediatrics. Could you comment on the role of the interagency? Most of the discussion focused on Department of State activities. And in particular, do you see a role for the DoD to somehow affect this? Thank you.
Thank you. Okay, we're going to start with these three questions. The first one around research, the second around accountability relating to donors, and the third, the interagency, particularly DoD. So why don't we start with Sheba and we'll go down the line.
Okay, I will do my best. I think, the research question I think is a really important one, and I'm not at all sort of an academic or research expert, so understanding exactly how to design or add on to existing services, but I think it's a really interesting point because I do think, as I noted and others, right, there's a challenge with only understanding when this problem is arising, when it happens that a woman or a girl is going in for a particular set of services. So I think that's definitely something to think about. I mean, I think I highlighted the need for better research around risk mitigation and the impact of risk mitigation measures, and so that is a place that I would also focus attention. But needless to say, I mean, this is an issue that is still shrouded by silence, and there are multiple reasons for that, which I think most here would be aware of. So finding some creative ways to tackle that. I think is, I applaud you for putting that on the table, but I'm sorry I don't have any immediate better thoughts on how to do that. I think the accountability question, for sure, to continue donor support for really important things like the real-time accountability framework, which we're working on in collaboration with OCHA and others, to also understand, and you picked this up in your question, but just there are myriad ways in which operating agencies are funded actually, makes it harder for us to be truly accountable to the populations that we are serving because of the kind of upward focus that we're constantly required to have. And so thinking through different ways that we and others would be funded so that we can really get at this transfer of power, and certainly tackling some of the kind of endemic challenges and longer term challenges that we know are some of the sort of the drivers of gender-based violence. I think the interagency question is an interesting one. I don't have an immediate reflection on the DoD question. I mean, I would say that from a funding perspective, obviously, it's both State Department funding and USAID funding when you're talking about funding going to operating agencies and in support of the kind of work that we've been talking about here. And obviously, there's more than just the U.S. government. But I think for sure, I hope that what has been reflected on the panel today suggests that it is important for any actor that is operating in these contexts to understand the prevalence of these issues and to in your own organizations both be tackling the gender inequality and other power imbalances that may be driving, whether inadvertently or not, right, driving further the ability for these issues to take root or challenging our ability to address them appropriately, and to being, to being open to partnerships in the right kind of ways, to learning from on-the-ground actors, from operational actors and others about what is going on in this space and how to best conduct your own activities, whichever agency you might happen to be, so that you are not yourselves, again, whether inadvertently or not, adding to risk rather than mitigating risk.
Okay. I will respond, I think, only to the question that has to do with accountability. From civil society perspective, honestly, it's a big issue for us, not just ensuring there's accountability, but how do we hold actors accountable? You know, it's been said severally, putting affected population at the heart of the work that we do, ensuring accountability to affected population. But then how do you hold donors and other actors accountable? It's still a challenge. There's no clear-cut guidelines or modalities to ensure there's accountability. So as far as we are concerned, it's just still, sorry to say the big English that we just get to speak, but it doesn't translate to anything. We hear it over and over, but we can't do anything about it. We cannot say or hold all actors accountable. So it's just sadly not.
So, maybe first just to pick up on your frustrating point, Fatima, which I agree, is, this is a huge issue, and donors have so much power and influence because they can really prioritize and decide what gets done. And if you're in the position of an organization receiving money from a donor, and the donor says, I'd like you to do A, B, and C and approach it in this kind of way, you're going to really think about that very carefully. So I really hope that all donors, sort of pick up a lot of what's been discussed today about how we need to approach things. So that would sort of be my first point. I think, Fatima, you're absolutely right. There's a huge gap between what we all say and then what we end up being able to do. It's something in the context of this conference in Oslo that you were at, we hope to break down a little bit by actually having an accountability framework around the pledges made at that conference. So at the end of this year now, we'll start an analytical process looking at what happened. It was pledged in May, and then about a year from now, we're going to do a follow-up and hopefully be able to hold people a bit to account for all kinds of things, including things like increasing support and funding to your own organizations. So let's watch that space. I think the other thing that's really important with donors is it's not just their money. It is their political influence and their leverage, which is so important in so many of these conflict-affected states. I was in Mali not too long ago and actually having a discussion with some of the ambassadors from the major donors there, and they have a huge voice in working with that government and in that context and trying to make sure all the issues we're talking about are considered within a human rights framework, which is super important. On the interagency issue, interagency processes are their own animal and driven by lots of different kinds of things, and I used to be in the U.S. government, so experienced some of this personally. So, I think the most important thing is that the process is framed around some key goals that everybody agrees on, because everybody's going to come at it in their own way. And I think, Janet, that's what's so helpful about your paper, is really you sort of outline a bit of a solution set for, what are 4 or 5 top goals that if the U.S. government wanted to proceed in a slightly different way, an interagency process could actually coalesce around it. I think that really has to be the clear starting point, and sometimes it's just not. So,
and certainly, let's just say that DoD has an important role to play and is especially key in the Women, Peace, and Security agenda. And I know a lot of work is going on there to advance that. So let's open it up for another couple of questions before we wrap up this panel.
Hi, my name is Kenley Flanagan. I work at PATH in our Advocacy and Public Policy Department. In my former jobs, I've also worked in the disaster response humanitarian aid setting, and I wanted to ask, what would be the ideal relationship in all of your eyes between local partners and the international community? And how can we better prepare ourselves to interact in a more comprehensive way that will enhance the local capacity? And what's kind of the ideal situation around that? Thank you.
Hi, sorry, I'm going to come from behind the pillar. It's Maureen Murphy. I'm from the Global Women's Institute at George Washington University. I'm really heartened to see everyone talking about research and evaluation and data. And Janet, your recommendation in the paper that we really need to be evaluating this work from the start. One of the questions that I have, kind of coming from a practitioner/academic, is how we best get the evidence that we do have in the hands of the people who need it in order to make decisions on the ground. And also for Fatima, how do we come up with research questions that are led by local women's organizations to answer the questions and empower you to do your work better?
Good morning. Carl Hoffman from PSI. The paper, the excellent paper, Janet, is focused on, in fact, the title of the session today is about the U.S. and potential U.S. action, and you make recommendations about what we could do going forward. But all of you on the panel have experience with the U.S., other actors on the global scene. In Fatima's case, you probably have experience or thoughts about other parts of West Africa where these same challenges are arising, and they are being responded to in different ways. I'd love to have perspectives on where you think this is being better handled. Where in the world are we getting good examples of how the integration challenge, the power dynamic challenge, the funding challenge, the leadership challenge are being well handled? Because I'm not sure it's here right now.
Thank you. I think we're going to go down the line. You can answer whichever of these questions you'd like and add any final comments before we wrap up the panel. So let's start with Sheba.
Okay, so I mean, I'm going to pick up a little bit, I think, first on the question of sort of how to work better with local actors and the sort of the localization question, because it's a particular bug. I have a bee in my bonnet about it. And I think, you know, as a starting point to just challenge even some of the language that we ourselves normally use, enhance local capacity. Well, to what standards are we enhancing local capacity, right? Like, why do we think we need to enhance it, right? In some cases, it might be actually perfectly well suited to the local context. And often what we mean by that is create mini us's, right? So that we can respond to our donors in the right kinds of ways, or empower local actors, right? And sometimes empowering local actors may be as simple as just getting out of the way ourselves. It's not that local actors don't already inherently have agency and have power, but it certainly is the case that in particular communities, for some of the very important and poignant reasons that Fatima put on the table, I think, women are denied that agency. And in fact, gender-based violence is used to deny women agency, to deny them the ability to access livelihood, access education, even to go outside of their encampment to collect firewood or what have you. And so, I'm just always struck that we've been at this for a long time. We've made a lot of rhetorical commitments to how we need to do this. And I think we know what we need to do. I mean, I think we have a good set of commitments that came out of the grand bargain, for example, around funding going directly to local actors, and certainly some of the work that I put on the table, but that also I think all of our comments have highlighted around the importance of just making sure that we are putting women's groups or enabling women's groups to be at the center of a response and at the center of leading a response, and that we ourselves are not creating responses that further deny them agency or further, like some of the issues around women-headed households and other things that Fatima was talking about. I don't know that I have a great answer on the kind of where is this being done better question. I will say that historically, the U.S. voice and leadership in this space has been very important, but I think we heard from Senator Murray at the outset about some of the ways in which that is challenged right now, so I don't know that I have to repeat that, but I think those were very important points to put on the table. And I do think that all donors do need to reflect on both how they drive some of the accountability questions that we've been talking about, but also how we get to a set of funding interventions that are not siloed, that are not solely technocratic, and that actually do enable organizations, local organizations and others to actually get at some of these root causes, right? You can't think that it's just a one-off treatment that is going to make this better, needless to say, but often that's the way the funding is channeled.
I think I will start by responding to the question on ways of working with local actors, basically localization. Localization is the currency of the day, but sadly, it means different things to different actors. There's no proper understanding of actually what localization means. So until we reach a point where all of us are on the same page as to what we really mean by localization, and probably have one agency or organization leading the localization process, probably that will be like a point of contact. It will be much easier for local actors to flow. But most importantly, like Sheba actually stated, is for local international actors to actually recognize and appreciate the capacity that exists locally to strengthen and to share experience. You know, this idea of always building experience and always assuming that it is the international that will build the capacity of the local needs to change. When you go into local context, you have to know that there are areas where the local actors need to actually build your own capacity. So that complementarity needs to be understood and also strengthened and emphasized if we want to work with local actors. Secondly, on the question that has to do with research and probably engaging women groups, it all ties on to the capacity that exists locally. There are a lot of women groups and women in the academia engage in different kinds of research. So it's just to recognize that capacity and also involve them in the research to actually give the research that, I don't know, that touch of somebody from there being a part of the research and actually contributing to it, because most of the researchers that we get doing research in these fields actually come from outside. So it's good to have that perspective from within, and I'm sure it's going to add a lot of substance to what we're researching on. And then reintegration challenge, just like you, I don't think I have the perfect answer to give, but I'm an advocate for homegrown solutions, because whatever model exists elsewhere, we cannot copy it. I think the best we can do is to share experience and learn from each other's experience. So it will be very wrong for us to assume that because certain things work in certain contexts, it will definitely be easier for us to replicate in our own context. So most importantly is just to understand what the root causes are, but then engage local actors and the people on ground to ensure that whatever solution is homegrown. Thank you.
I would just quickly add maybe two perspectives. The first is on this issue of capacity. You know, my own sense is 9 times out of 10, it's not the capacity of people, it's really systems, right, that underpin organizations that need to be supported. And, you know, I'll be entirely honest, I've looked on the web for my own organization about what one needs to do to apply for money, and I have a hard time understanding it. So I can only imagine if you're sitting in Maiduguri what it must look like, you know. So I think there's an important commitment we need to make sure we're simplifying our processes and helping very capable people have the systems they need to be able to access, you know, this funding. But the other element I think just it is important to be aware of is donors have an ever declining appetite for risk. So as we're being asked to do more with local organizations really at the forefront of crises, which is exactly what we should be doing, at the same time we're hearing, but don't please have any problems. So it's hard to sort of balance that, but we sort of try to do that every day. Carl, to your question, you know, I just think some number of years ago, it was when Joyce Banda was president in Malawi. I went to Malawi and looked at some of these programs, and I was actually really struck by commitment up and down the political leadership level, but then how that actually translated to services being provided at the local level in very comprehensive sort of one-stop shop types of settings. And there was a whole network of these entities that had been set up, and very clear coherence coming from the top through the ministries down to sort of the local provincial leader. And, it was all about really personal leadership and commitment and accountability. So, I don't know how one replicates that, but that seems to really be a key ingredient.
Before we close up and thank these panelists, I would just like to highlight one point that we're all aware of, but didn't really come up, which is the risks that those groups on the ground are facing. When Fatima was speaking the other day about going into the deep field, as she called it, and the issues that the local actors and the local women's groups and civil society groups are facing in trying to provide the sorts of services that they're providing, to gather the data that we are all so eager to understand. They are on the front lines and they are facing some very serious risks, and I don't think we are as aware as we should be about that sort of what we owe to them and the dangerous nature of some of the work that they're doing. So I would like to take a moment just to thank all these panelists. I think they have all brought important perspectives to some very complicated issues at a very complicated time in our own political life here. But I hope that with these thoughts and with some of the recommendations that you'll see in the report, that we can understand that these are important issues that have a place in and of themselves of importance, but also as an element of global health security, and that we should be looking more broadly at ways that we can be identifying the gaps and what are concrete ways that we can move forward. And I look forward to working with all of you on this going forward, but certainly want to take a moment to thank our panelists who did such a great job. So thank you. And we'll move to the next panel.
I've already learned a lot, look forward to learning more. And I have three great panelists here, and I'll introduce them in a second. First, just a couple of introductory comments on this topic. I had some thoughts prepared, and honestly, the things that were discussed already in the first panel caused me to jumble up everything that I was planning to say, because there's so much to be drawn from and to build on in what the previous speakers spoke about. I think the framing of the overall session about U.S. action is the right way to frame it. I think the question that I posed earlier was, it's not just about the U.S., obviously, although the U.S. has a preponderant role in so many things, positive and negative, let's be honest. But it's about action. Right? It's not simply about taking stock. It's not about understanding the phenomenon. It's about what can we do to drive better and faster action. I think Lisa's comments, and in fact the previous panel in general, but certainly Lisa's comments about how it's a mistake to look at issues of gender-based violence as an add-on, and Sheba made this point as well, as an add-on or as an adjunct to a program that's already been developed. And the report draws this out in other ways, too, I think citing the ICRC President Peter Maurer in this regard. This idea that we need to get to the point, whether it's about GBV or women's health needs in general, we need to get to the point where these are opt-out issues as opposed to opt-in, right? These need to be baked into the humanitarian response, but also the development response wherever we encounter the need. It's a mistake to assume that these can be added on. They have to be conceived of right from the beginning and central to the enterprise. We heard the statistics already. Tens of millions of women and girls of reproductive age in crisis. Those numbers likely to go up. And the system as a whole or ourselves falling short of meeting the needs of those women and girls. We recognize that the failure to meet their needs in crisis settings exacerbates crisis, leads to deeper and longer lasting crisis. It's the classic vicious cycle of problem, begetting problem, begetting problem, and growing bigger over time. So our challenges are significant in front of us. I think we had a good discussion, the beginning of a discussion about power. This discussion needs to be central to all of our work. We recognize that it is the sort of defining characteristic of the development challenge and the humanitarian response challenge. It's power, the power dynamic and disequilibrium between men and women, between North and South, between international and local, between national and subnational. And if we don't understand that at the outset of trying to organize our response to challenges, then we're doomed to perpetuate that power imbalance. And I think, this is a lesson I feel like in my own organization, we sort of relearn every day. And it requires great humility to be reminded of that. The need to constantly put your, might say beneficiary, we at PSI would think of her as a health consumer, to put your consumer at the center of your programming and to start with her barriers, her realities, the needs that she must meet. How can we get inside of her? How can we learn from her reality, as Fatima pointed out, so that the capacity that's developed is from outward in as opposed to inward out. So many things to learn in that regard. I think, as we sit in Washington over the last 20 years, we can think of what's happened in the world of international affairs and the events that drove the American response to the world over the last 20 years. And when we think back to the dawn of this era, of this century, in terms of the US role in the world, it's often described as a failure of our imagination as a government to recognize the global threat that we faced and therefore to be prepared and resilient when it came to us in 2001. I think we face a similar problem here. We talk about all of the steps that we could take. The paper puts forward a number of practical suggestions for how the US government could organize itself better to act in response to these challenges. But I think we would all agree that what's proposed in the paper, and Janet described it this way last night, it's a pilot. It's a set of suggestions about ways to approach this incrementally. And we should ask ourselves if we are simply failing to imagine bigger and more ambitious ways to address the underlying problems here. All of us contribute somehow to this incremental progress, we hope. But the challenge is broad and deep. And so we should, I think, ask ourselves if we're failing to imagine a bigger way to respond. And certainly on the question of how to get women's health, and particularly women's reproductive health services, quality women's reproductive health services, into disordered settings and into the general development context is one that is a worthy challenge for us today. So we have three experienced and strong leaders who are going to talk to us about that perspective. You all also have seen their bios. First, we will start with Lara Ho, who's Deputy Director of the Health Unit for the International Rescue Committee, where she supports projects in primary health, environmental health, nutrition, family planning and reproductive health, child health, health systems and health research. There's nothing that Lara doesn't do. After that, we'll hear from Beth, who's the Executive Director, Beth Schlachter, who's the Executive Director of FP 2020. Look forward to being together next week in Nairobi for ICPD Plus 25, Beth. Also had experience in PRM within the State Department previously in her professional work. And next to me is Hannah Tapas, Senior Monitoring, Evaluation, and Research Advisor at JPIGO and Associate Faculty at the Department of International Health at Johns Hopkins, where she focuses on expanding the evidence base for health services delivery and multi-sector approaches in conflict and disaster-affected settings. Lara, let me ask you to kick us off.
Thank you so much for having me here. It's really been great to hear the previous speakers. They've actually highlighted a lot of the points that I want to talk to, so I will try not to repeat them, but perhaps expand on them with some real-world examples. And thinking about the different themes, one of the things that came through that I would like to emphasize is really the need to listen to women and girls. Women and girls know what they want, they know what they need. And in terms of providing services, if we look at what most ministries of health include in their essential package of health services, this includes maternal health services and family planning services. This is also borne out in the minimum initial service package for reproductive health and emergencies. All these activities are included. But often what we see on the ground is certain services like family planning are overlooked. So in Northeast Nigeria, when our reproductive health coordinator arrived, she found that the health cluster had prioritized child health and communicable diseases, which are important and essential, but they had really overlooked some of the other services in maternal health and family planning. So she actually set up a sub-working group for reproductive health, which is often something that is a normal part of a health cluster, but it's often overlooked and it's not set up in a lot of areas. And when we first opened our women's center there, on the first day, 300 women showed up seeking services, and many of them were looking for family planning. And so this is just an example of women want these services even in an emergency. They want them when there's no emergency, but often these needs are exacerbated in conflict and crisis. The second point I wanted to touch on was about localization that's been brought up in the previous panel. And IRC likes to look at this as really as partnership, right? It's really a partnership between different actors who bring different things to the table, and it's a relationship of mutual respect and contribution to addressing the needs of women and girls. Local actors have deep understanding of the context. They may be able to reach populations, particularly marginalized populations who are not having access to care. International actors can bring experience navigating the humanitarian architecture that local partners may not have, and this is really a complementary relationship. The IRC in Syria, in northwest Syria, all of our activities are implemented with local partners. For reproductive health in particular, in both Serbia and Colombia, we work with local partners who are the service delivery providers. We don't provide services ourselves. We support them with technical assistance, with funding, with expertise on how to navigate the humanitarian architecture again, because these are highly experienced partners, but who may not have worked in humanitarian response specifically. Finally, related to that is the issues of integration and adaptation. So one thing that IRC has done is looked at a model for comprehensive women's centers. These are safe spaces, for women-only spaces, where we are able to provide both case management for GBV, psychosocial services, legal services, life skills, women's empowerment, and in addition to that, reproductive health services. I visited one of these centers in Yemen. We've done this in northwest Nigeria and Bangladesh, and in Yemen I visited a center where we have a program called Girl Shine, which is focused on young women, both adolescents and youth. And I remember meeting one woman she was 17, she was already married, and in talking to her, I asked her about what she wanted, her hopes were, and she talked about wanting to learn more about healthcare so that she could share this with her peers and her friends and inform them about what their options were and what they could do. And so one of the things we've done is we have midwives based in these comprehensive women's centers so that women who are participating in other programs about life skills, about having communication with their partners or with their parents and their family members about what they want, can also access health services, whether it's antenatal care, whether it's family planning, in a safe space that is a women-only space. And it's quite motivating to see how these women who are going through these programs really start expressing their needs and are empowered to make decisions for themselves and have access to these different services. Particularly for adolescents, it was mentioned that in crises, adolescents are often at increased risk due to various reasons. And so one of the things we found, looking at our data in our programs in DRC, we noticed that utilization of the family planning services was somewhat low among younger women. We were having good uptake among older women. And so we started investigating, and what we did was we looked at a participatory action research project, which in this participatory action research, this means that the participants are the researchers. We're not the researchers. We had groups of adolescent girls and boys, healthcare providers, other community leaders, and we facilitate a process where they're the ones who have the knowledge, they're the ones who generate the knowledge, they analyze it, they think about what they can do to address the problems that they themselves have identified, and we support them through this process, through several meetings that are done with the different groups. They're brought together to then collectively plan how they can address some of these issues. And basically after this, we found that uptake of services increased significantly among adolescents because they were able to understand what was available. Healthcare providers were sensitized to what the needs of adolescents were, which are often different from older women. And we've since replicated this in Northeast Nigeria and South Sudan. And again, this goes back to listening to women and girls, and they know what they want. And often there aren't venues for them to express these needs. So it's really important to create these spaces for them to be able to talk about what services they need, how they want services delivered, and then for us to be able to adapt to that. So thank you.
Thank you. Thank you. Beth.
Thank you, Carl, and thank you, Janet, for your report. I think it's extremely helpful to help government think better. And sometimes you need external partners to look at you and reflect back new ideas so you can do what Carl asked, which is to have a bigger, more ambitious imagination to help solve persistent or escalating challenges and problems. And thank you, Laura, for the examples of what can work. Because part of what I've seen in the work that I've done is that change is often blocked because people's lack of experience or imagination, or a worry that change means that you're going to do less of a thing that you're already doing. And by helping us to see how we can do more together and more efficiently through partnership, I think it helps get rid of some of those blockages. I'm impressed looking around the room that I see so many women. I welcome all of the men who are our partners, both in life and in work. You know, power to all of us, right, Carl? But we're not going to solve these problems if we don't better understand each other. And the generation of women that are in this room are going to be those who are going to help us to move this forward, because a lot of what we're talking about is normalization of understanding women's bodies and lives, but in this situation, in the context of crisis and displacement, and recognizing that crisis and displacement themselves are complex in a range of different situations. What we've had in the past has been a system that's dealt with the necessary things that were considered at the top, right? Shelter, food, safety. But for women, that includes their bodies as well. We heard about GBV and all of the statistics and the numbers, and I think you're in this room because you're aware of that. These are escalating crises. More of them are happening. They're happening for longer times, and more people are involved. And so our understanding of that has to transition as well. But we need to recognize that within that, it's more women, it's adolescent girls as well, it's adolescent boys who, as we heard, also experience a lot of gender-based violence. But it's only women who are at risk of unintended pregnancy and who bring with them the daily needs of dealing with a body that has its own reproductive health cycle. And I'm pretty sure that there's not a woman in this room who's here without having addressed her reproductive health issues. And I'm pretty sure that very few of you would be satisfied with sort of a CVS response to your reproductive health needs. You know, power to condoms. I think that they are the revolutionary product that, if nothing else, if you have a condom, you can help protect yourself from pregnancy and HIV to the extent that you have the capacity and the power to ensure that that's used. But a packet of pills and potentially a condom are probably not a sufficient method for pretty much everybody in this room. And it's the desire to bridge that gap between what all of us can have and what we expect systems to deliver, recognizing that they're going to be able to do different amounts of this work at different times. That's evolving as well. But if our ambition isn't around ensuring that women and girls who are more vulnerable to sexual violence and who probably have a better reason for not wanting to get pregnant next week because they're in displacement. How can we normalize what we expect that they should be satisfied with? And then how do we look at our systems so that we're doing what Fatima is really bringing all of us to look at really closely, which is to understand that women understand what their needs are, but they need us to help make those systems of delivery better and response. And so what all of us in this room can do is to ask ourselves through our work and our programs and whatever power we have about how we can work together more efficiently and effectively, and then how we can demand that our government also respond more efficiently and effectively. Because this government, we're all very aware, has different ambitions depending on which administration is in power. Traditionally, the work for supporting refugees has been work that has been supported in a nonpartisan way. Republicans and Democrats supported work to support refugees, but that reality has changed. And we need to be able to ensure that we're pushing into this and saying that the incredible expertise that American systems have needs to not only maintain that, but also work together more efficiently and effectively. And again, I bring you back to Janet as a thought partner in this and in this report of helping government to get out of its own head, its own silo, its own necessary need to protect what it's doing, because there's incredible expertise that is siloed, but to help us all learn that as we partner in new ways to look at women and to meet the needs of women, we need to think differently as well. And it's going to take all of us thinking differently ourselves that's going to help push into that system so that we change these operating frameworks, we change the habits of how we work together, and we open that up to solve problems better together. Because there are still incredible resources, there's incredible capacity in the US government that can partner with local capacities and skills to help resolve some of these sort of systems and processes that we all inherited, but we're all now, you've taken on the obligation by being in this room and saying you want to work in this sector, to learn more and to work better together. And if we can all open our minds to that potential as well, then our colleague here at the DoD who wants to know how we can more effectively work with the DoD and their resources can help the State Department, can help USAID, and then can help all of the implementing partners who are funded through those resources to all of us work more effectively together. I come from FP 2020, which is a global partnership that only exists because the US government can't pool their funds on family planning with other donors. We can't have a Gavi or a global fund for family planning because of the funding restrictions that are placed on US government investments in family planning. And yet, US government assistance for family planning in development alone is almost 50%. And that's only counting the annual allocation. It doesn't account for all of the people working on family planning around the world. So we're restricted in our ability to work with others because others don't want those same restrictions added to their money. So we have a partnership of collaborators who are committed to working together, recognizing that there's that restriction on how it is that we can even partner effectively. But through that, we've also learned that there's a lot of goodwill and intention that comes to that partnering. The way that we work with local development actors in countries is we ask them to make a commitment to what they want to do for family planning. And then we work with them through technical working groups in countries that include USAID and UNFPA in pretty much every country. And even though those funding restrictions that everybody, I think, in this room are pretty well aware of, exist at a funding level, at an operational level, USAID is still working together with technical partners and UNFPA because country commitment is in the lead about what they want to achieve. And the whole goal there is that people sit around the table and they learn from each other, and then we bring countries together so countries can learn from each other as well. And we've seen a lot of capacity building and just normalizing of working within this challenging environment because countries and then country teams have more opportunity to learn from each other and work together. So we know that the more that we bring together disparate partners, the better outcomes we're going to have. And yet still within this framework, we're struggling to work with people outside of the development sector, even though we recognize that most women are vulnerable to displacement or living in fragile settings. And Nigeria, again, is a perfect example of this. I can't imagine a more complex operating environment for a minister of health than Nigeria, where you have Lagos as one of the most dynamic and fastest growing cities in the world, and then you have Borno and the Boko Haram reality and dealing with all of the challenges there and having to work across such a complex environment. It requires all of us as partners to understand that and then to support the work of the government, of local actors in order to meet those realities. And there's great potential in that. We've seen great growth, and we know a lot together in systems. So I think your plea, Janet, to greater partnership both within the U.S. government and then from the U.S. government to other partners is one part of this solution. And to bring the word that you said early on, Carl, of being humble to all of this is I think, really important, because the U.S. government continues to have enormous resources. But to be humble enough to say that we need to learn from local context and partner with that. The humanitarian systems themselves need to be humble to be able to adjust to any specific context is really critical. And then to ensure that we're all looking at the needs of women and girls to drive that response. I think that's beginning to flip a bit, and that people are talking more from that context back instead of what we know and what we're going to give to you. And that's going to take a long time to shift, but we have partnerships and potential in there to do that. And we've seen that where women and girls have access to contraception, that they want to use it, including to long-acting methods. And so I'll stop with that, but I do think there's great potential in all of this, and I do want to thank you for bringing us together to think about this and to think in new ways.
Thank you. Thank you, Beth. I mean, fantastic. I really appreciate the ambition you've articulated there, and a reminder that that description of young people in long-acting methods, of course, is true in the developing world context, also in the U.S., seeing exciting things happening in that regard, and a reminder of all the capabilities that are out there and how we need to organize ourselves better to respond to the challenge. Because the challenge, by the way, is not stagnant, it's escalating. So, Hannah.
Hi. So I want to start echoing everyone's thanks for bringing us here today and for the opportunity to participate in this important conversation, as well as for the report and the previous speakers who really highlighted both the challenges and a lot of potential opportunities for us to expand the reach of health services to women and girls in some of the most challenging settings. Before we go into discussion, I want to shift gears a little bit to reflect more specifically on maternal health services. And a few things that have struck me in my work in a number of different settings. One is the stark inequities, and I think this has been highlighted in some of the initial conversations this morning and in the report. The high-level statistics of the risk, a woman's lifetime risk of dying during pregnancy or childbirth is close to 1 in 5,000 in high-income countries, and 1 in 54 or 55 in low and middle-income countries. And that's not looking specifically at conflict-affected or crisis-affected settings, and looking at sort of the aggregated statistics on a national level. Beth just highlighted the example of Nigeria. You can imagine the difference in the risks, the care, the health outcomes, between a woman in Lagos and a woman in Borno. But even within, the more local we get, the stark disparities are even more clear. I'm sure within Borno, as was within many of the places I've worked, within a small village in Afghanistan, the difference in care that one family is able to access through their connections, their means, their resources, and the more marginalized women, the risks are enormous. And so just to sort of start with that, I think that's quite striking. But the disparities, to put a more positive spin on it, it also shows that even in these hardest settings, good care is possible, that with the right investments, with the right resources, women are able to have quality health care, families are able to have quality health care. And so that takes investing in health systems, really. And that's one of the challenges with maternal health, is that it requires a whole systems approach. Care during pregnancy, care on the day of birth, preparation in the event of an emergency means having access, not just knowledge or access to commodities or services, but being able to reach care, quality care, with in a timely manner to address an emergency that you don't know when that will be occurring. So the linkages between strengthening health systems and gender, peace, security issues are enormous. And it takes more than a health response to address these, but that involves bringing in others. So the other areas, within the health system that requires investing in a health workforce, investing in supplies, technical capacity, as well as protection and responsiveness of health services. And so that's the part that I want to focus on a little bit, is the health workers. And who is the health workforce that needs to be supported in these settings. And the reminder that in most crises, the health workers are not Americans flying in to provide services. They're people from those communities or close to those communities and viewing areas who are also living and working in these extremely challenging settings, are mostly women. The majority of maternal health care providers are midwives and nurses. And they're also mothers, sisters, neighbors, have these same threats, challenges that was highlighted in the GBV panel, affects them just as much. The threats to health workers are enormous. And I'm not talking about the increasingly now prevalent, attacks on healthcare and targeting of hospitals and health workers, but the everyday risks that health workers take to be able to do the job, whether they're receiving their salaries or not, the traveling through roadblocks to get to work, worrying about whether their kids are going to come home from school and if they're okay, while they're trying to provide care with limited supplies, resources, in a very challenging setting. The power dynamics that were mentioned earlier, bringing voice to these women, because what really at the center of care is the experience of the woman and her healthcare provider. And we have evidence, we have research from many crisis-affected settings, from many non-crisis-affected settings as well, that where quality care is available, people will go, but one of the bigger deterrents is not security, but is quality of care. So I think raising that question of what do women want, but also what do healthcare workers want? What do they want together? What would help break down some of those barriers to help them do their job? So with that, I'll pause and maybe we can discuss more examples in discussion.
Great. So mental health and what to do when conflict is over, the inclusion of most at-risk women in field trials and PLGHA. So who would like to tackle any one of those? Laura.
Sure. So really important question about mental health and psychosocial care. Within IRC, this falls across two of our departments. So we have teams who work on the GBV response, and they work mostly in psychosocial care. Within health, we do work on mental health. And so we've been doing a lot of work to try to integrate this into our various programs. So certainly in GBV response, psychosocial care is a key part of the case management and access to that. And then within primary health care, we're doing more and more work to integrate mental health into our primary health care services, and also linking the continuum from mental health to psychosocial care. Regarding healthcare workers, when I worked on the response in Sierra Leone during Ebola, and one of the things we found was the huge trauma experienced by healthcare workers who were stigmatized themselves, who were dealing with really complicated cases, were scared themselves of becoming infected. In Liberia, we actually had a program post-Ebola to look at promoting self-care for healthcare workers to help give them the skills to manage some of the stresses that they were facing there. And we had some positive results on their ability to manage their stress in their daily work there. So yeah, I think that answers that question.
Thank you. I wish I could say I had the expertise to answer your question about R&D, but I'm sorry, I don't. When it comes to mental health care as well, I think that we need to do more that understands reproductive health care within the context of mental well-being. We know that when women can control matters related to their fertility, that obviously has an impact on their mental well-being as well. So I do believe that contraception and access to family planning is a component of that. It's a factor. So we are not right now aligned with mental health care efforts, but I think there's enormous potential to do that. And so thank you for raising that, because I believe there's a lot more to do. When it comes to PLGHA or Mexico City policy or the global gag rule or whatever your favorite way is referring to it, I do think there are partners who are effectively tracking the impact of this, particularly in development settings. I would refer you to our partner, PAI, who is tracking this by country and has information available on their website should you wish to see that. And it does so in many countries that also include complex operating environments. But to my knowledge, there has not been an organization who's done the research and analysis on humanitarian settings. We're still waiting for a report from the State Department that was supposed to be an update to the information that was given last year. That has not yet been provided. So I think we can all do more to continue to put pressure on the State Department to share with us their internal assessment of the impact of PLGHA on humanitarian funding. And there's a lot more to learn from that as well. So I'll just leave it at that.
Do you have any thoughts, Hannah, on the RCT question?
Sure. So I think we often say, to some extent, we know what works. We actually have more evidence out there than is sort of given credit for how to provide health services in emergencies or what services to provide. But that is with, I think, two major caveats. One is the how to do this in different, very complex settings is something where we can have a lot of learning, and there's a need for more implementation research and evidence, but we're never going to have a recipe book. Settings are complex, and it is about adapting to the local context and learning what works and gathering data and using that data to make decisions. The second major caveat is the complexity of needs. And while we know how to provide quality care, we know what clinical interventions are effective for women experiencing complications during pregnancy or childbirth, we don't know all of the complexities around overlaying infectious disease outbreaks, overlaying extreme malnutrition, all of these complexities, and there is a great need for more research in some of these areas. The question specifically about R&D for new vaccines and trials is a very complex and tricky one, but there's absolutely a need for more research and ethical, well-planned, well-funded research, not ignoring this large portion of the population. So.
Thank you. Did I see a hand back there earlier? No?
Can I respond to
Please.
one? So I also wanted to quickly respond to the question about mental health, because I think it links back to our previous discussions around self-care, and there's a lot of emerging research and guidelines that some colleagues at Johns Hopkins and WHO and many other organizations are looking at around psychosocial support, self-care for mental health issues, and there's some areas where I think that's a great opportunity for integration. So whether it's integrating mental health aspects into antenatal care, into other maternal and child health services, or into curricula for health workers. And an area that's quite important for emergency preparedness and response. I think most of the examples where we have started to do this a little bit more, and many organizations are working on it, are following major crises like Ebola, or in the as a reactive method. So I think something we can look to in terms of development programming as well is more integration of mental health across the board.
Other questions? Yes.
Hi. Hello. Sorry. Paige Wallace from the National Association of County and City Health Officials. I had a question. I know Hannah mentioned it earlier, the stats on 1 in 5 women in high-income countries have complications while pregnant, and the disparity just gets different as it goes to developing countries. And I know the U.S. has a unique situation, a current crisis where the disparity, when you break it down, it just becomes more and more troubling. How do we address the biases and challenges in healthcare providers when dealing with maternal health?
Yeah, great question. You want?
Sure. So I think it's a very complex question in any country, in any setting for sure, but an anthropologist who's done a lot of work in Afghanistan over years recently published an article that I thought was very poignant, sort of challenging two narratives about healthcare workers, that they're either presented as victims or as villains. And in the context particularly of respectful maternity care and some of these challenges. And the reality that, as we've been discussing, it's much more complex. The challenges that healthcare workers face, the gender biases, the professional challenges, the working environment, creates a setting where it's not malintentioned, but the interactions are not always positive. There are also personal biases, and so I think understanding all of that, the social behavior change work, focusing on providers, creating a supportive environment for all health workers, giving a voice to maternal and reproductive health workers within the health system are all really important.
Janet.
Thank you all for such an interesting panel and so many different interesting perspectives from your own work. One area that you haven't yet touched on that is something that's talked about a lot in the humanitarian and development worlds is this nexus, as it's often called, between relief and development. And one of the areas we see that most acutely, of course, is in these issues of maternal reproductive health, family planning. How do you link from the acute emergency to a longer-term, either protracted crisis or into a development agenda? And we see that, as it's mentioned in the report, with the new work that the Global Health Bureau of USAID is undertaking, how that will link to its longer-term development work. And I wonder if you could reflect on these issues and these complexities of carrying this work through the spectrum of acute crisis, protracted crisis development.
Great. Any comments?
Sure, I think that's a really important question, and some of the issues that we've talked about, I think, speak to that. So I think one thing is, when we're responding initially in a humanitarian response, to think about how we can incorporate systems strengthening into our response and how we're responding. So in some cases, when IRC goes in, we look at whether we should be supporting Ministry of Health facilities if they are there and if they are functioning, rather than providing direct service delivery, and the idea of partnership. So again, there's a lot of local partners who are already delivering services on the ground, and thinking twice about whether it makes sense for us to international partners to set up services, or whether we should think about partnering with local actors, again, whether they're government or civil society, and thinking about how that we can build in long-term sustainability so that it isn't a sudden shift where suddenly you leave and things end, but you're thinking about the transition from day one.
Beth, before you answer, I just want to note that last night, I think you were the one last night at dinner who pointed out this reality that, the focus of the conversation is around meeting the reproductive health needs of women in crisis, which kind of presumes that once the crisis is over, they don't have any needs anymore, right? Clearly wrong. So talk about that.
Yeah, I was thinking, especially as you were speaking, Laura, about, and there's this whole spectrum, right, of resilience planning and immediate relief and then recovery and back maybe to a development framework or back to whatever normal is, and then trying to improve on that and to ensuring that the needs of women are considered across that. I'll get to your question, but the thing that's in front of my head that I have to get rid of first before I can think about that is around resilience planning and about how much opportunity there still is, because really nobody owns that space. People work in humanitarian, people work in development. But this nexus that you're referring to of where those things come together and the potential there is something that we're all beginning to explore. And that's where I think these ideas around how we partner together better for longer term solutions is so important, because we all know in our lives that the better you plan for something, hopefully the better outcome that you're going to have on the back end, right? And I'll give an example from our workshops with countries. Last year we had 15 Francophone countries from Haiti to Madagascar, mostly African, but also Haiti. And we wanted to understand what the planning reality is with regard to resilience. What are you planning in your countries for disruption? Because for disruption, it's not a question of if, it's when. And so we asked people, are you vulnerable to flooding? Are you vulnerable to earthquakes? People had a little bit of fun with that, Are you vulnerable to potentially violence or displacement? Everybody stood up for one reason or another. And then we asked, does your government have a plan for how to address that? And 2 country teams stood up. And remember, these are governments, USAID, UNFPA, civil society, youth partners. It was Haiti and Chad. They had a plan. And then we asked, all right, within these plans, do you know if it includes family planning? And nobody stood up. And so I do think there's an enormous gap there, both to work with the people who are on the ground, to give them the tools of what does resilience planning mean, and what does it look like, and how do you start to interrogate your systems to see where the gaps are and where you can bring your expertise into that conversation, or perhaps generate that conversation yourself, and then ensure that it's then aligned with humanitarian response on the one side, and then development or systems as usual on the other. So there's a big gap there that I think we all have to start asking ourselves. Okay. And then, with regards to women, I actually can't remember exactly what I said last night, Carl.
But it was memorable.
It was memorable. I felt it at the time. I think it was more about, yeah.
It struck me, it's just this, I think it's related to this, the tendency to think that there's this problem, we solve it, and then everything else is solved. Yeah. And it's not that. It's a transcendent set of requirements, right?
Well, and we had a woman who came and spoke to the FP 2020 reference group, which is really the leaders of family planning and many ministers of health as well. They meet a couple times a year. And she was an HIV advocate that was a part of this ECHO trial that many of you may know about the interaction of the impact of hormonal contraception on HIV acquisition. And what she said that's so frustrating to her is she's considered an HIV advocate. And she said, I have one body. It's vulnerable to HIV, it's vulnerable to unintended pregnancy, and could you all please put the body together again and consider me as one human, and then work with a system that designs for that. Yeah. And so maybe it's that body that gets carried forward.
Powerful.
We're referring to.
Hannah, any thoughts?
Yeah, I think going back to the workforce issue, I think this is an example of where longer-term funding and longer-term thinking is often needed to support both, say, today's workforce and tomorrow's. So in settings where, health workers may be displaced, may be leaving, may stop working for issues ranging from security to, all sorts of other reasons. But thinking about how long it takes to train a new midwife, to identify someone, and investing in those development-oriented things, not waiting until a crisis is finished, and then we have some time, and then we can restart our school, and then you're still 3 years away from having your first graduate. So exploring, there's many examples from South Sudan and Yemen and elsewhere of ways to start this earlier.
Thank you. Well, I think it's time for lunch now, actually, but before that, let me invite you to thank the panelists. And I believe lunch is served next door. Thank you all.
Very tricky.
Hi, all. Susan, we wanted to use this closing segment to hear from 2 members of our commission, Congresswoman Susan Brooks and Congressman Ami Bera, about how to move this agenda forward. We've had a chance to very briefly summarize what's happened today, and Congresswoman Brooks has to rush off to catch a flight, but she's kindly come over here to be with us. So what we're going to do is just go straight to her. She's prepared some thoughts around the report and the agenda and how to move it forward here within Congress. And if you have time, we'll take a couple of questions, but if you don't, will understand. So thank you so much for all the work you've given us and guidance for the commission, and we're thrilled to have you here today. Thank you.
Thank you. Hello. Okay.
There you go. It's on.
Is it on now? Yes. Okay, there we go. Hello, everyone. Wonderful to be here. Thank you, Stephen. Thank you so much for having me today. And I understand that you've had a great conference so far and wrapping up. Happy Halloween, by the way. And I'm really tired because the Nats won last night, okay? And I can't stay up that late, night after night after night. And so we're all dragging, right, Ami? I mean, we're all dragging today, but it's an exciting thing in this city. And so I hope for those of you who've traveled to be here, I hope that you've enjoyed being in the city last night. And if you happen to be here through Saturday, apparently there's going to be a big parade. And, you know, keep the festivities going. And I'm a Cubs fan, but I became a Nats fan. Anyway, I do represent Central Indiana, but more importantly, I have served as an advisor or a commission member of CSIS and focused on health concerns, and really am pleased to have all of you here. Actually, my flight's been delayed because I have another meeting I have to get to, but I am sorry I'm not able to stay here for very long to take questions. Actually, Erin McMiniman, my able, incredible staffer, senior legislative aide, is here to take questions. If I said, why don't you stick around? Because how many of you have been congressional staffers or are congressional staffers? If you are, you know that you all typically know all the answers and get us ready for everything. So quite frankly, Erin is incredibly able and capable to assist my good friend and colleague, Dr. Ami Bera, with any questions that I won't be able to answer. But we know that the United States does lead the world in supporting health and humanitarian responses, but we also know, as was pointed out, that there is certainly more that we can do. Actually, I met with a group of German leaders this morning and, you know, have talked about so many things that bring us together, different countries in Europe. And we do have, as the United States, a unique ability to intervene in times of crisis, unlike many of our other peer nations. But we need to bring our peer nations along, and I think need to be setting the bar and finding the way to lead, and certainly in places and times of major disorder. I am proud to serve on the CSIS Commission on Strengthening Americans' Health Security. Every time I attend a meeting, which I really enjoy, I learn so much. And I see all of the incredible people that you have assembled on that commission. And so many people focused on the one that I'm focused on is biodefense and preparedness. I've been very focused on those issues for a very long time, but since I'm in my 7th year in Congress, the co-leader in the House of a biodefense caucus is Congresswoman Anna Eshoo. She has been very focused on these since she too came to Congress, but she's been in Congress. She got the original pandemic all-hazard preparedness bill passed back in 2006. That was after anthrax attacks happened here in our nation's capital in 2002, crippling our nation's capital. And actually, people died. It was a horrific biodefense attack on our nation's capital. But we do know that in disordered settings and in crisis time, women and girls are particularly vulnerable. We know that gender-based violence, of which many of you are far more expert at than I am, is often used as a weapon of war, and it has incredibly brutal consequences. I've been told, and numbers say, that about 34 million women and girls are in conflict and are vulnerable to these types of horrific crimes. The report posits there's a lack of focus, though, on a consolidated and a clear U.S. strategy to integrate our health and safety needs specific to women and girls in crisis setting, and that often other priorities often overshadow what our strategy might be. That's why I was really pleased that another colleague who I came into Congress with, Representative Grace Meng from New York, and I just saw her. She is running to jump on a plane. She has a 9-11-year-old, and she is going to trick-or-treat with them tonight. So I share that with you because often, I learned this morning at my visit with folks from Germany. They view that we, yes, are a very polarized country, and we are very divided on many things, such as the impeachment vote we just took on a very partisan basis. But that does not mean that we cannot work together on particularly health security issues, national security issues, and many other things. So Grace and I co-sponsored the Safe from the Start Act, and this bill seeks to inform all of our humanitarian responses in order to be much more thoughtful to the specific vulnerabilities women and girls face. And so it's the type of bill that focuses specifically on women and girls. I must say, though, and people might have not appreciated that in 2017, Congress did unanimously pass, and President Trump signed into law, the Women, Peace, and Security Act. In case you were not aware of that, it requires the United States government to promote women's meaningful participation in preventing, managing, and resolving conflicts. And I'll tell you a little bit why that's so important. This law builds on the research that shows that when women have a seat actually at the negotiating table during times of conflict, and I love that the gentleman over in uniform is nodding yes, so I love to see that, thank you. The prospect that peace negotiations will succeed rises significantly when women are at the table. Lack of engagement of women and girls in decision-making in their communities leads to less secure futures, less resilience. This past June, my very good friend, Representative Lois Frankel, a Democrat from Florida, we co-chaired the Women's Caucus. We sent a bipartisan letter to Secretary Pompeo urging him to ensure that women were included in the Afghan peace negotiations and that we had grave concerns about our government negotiating strictly with the Taliban. I had actually just returned Susan Davis from California and Martha Roby, Democrat, California, Martha Roby, Republican from Alabama, have co-led for a number of years a women's trip to Afghanistan. We go every year around Mother's Day. They've been doing it, I think, for about a decade to thank the female troops who are serving for Mother's Day in Afghanistan, that they expanded it several years ago. And since I've been going, I've gone twice now, women from government, women from nonprofits, women from NGOs, and women leaders from Afghanistan come to our meetings as well. And so we have really developed over, and much thanks to Susan Davis, have developed a strong relationship with the women of Afghanistan. The United States of America changed the women and girls' lives in Afghanistan when we ousted the Taliban. And this has been something that we cannot go back. We cannot allow, in whatever we do in trying to negotiate peace, which is very, very difficult in that area, women must be involved. And so we indicated to Secretary Pompeo that the significant gains of the Afghan women over the past 18 years have been because of the return. They are, I think, some of our greatest returns on investment by the United States. And since the Taliban fell in 2011, women have voted in elections. They are members of parliament. They are leaders. We've had the opportunity to meet them. And so it is critical that women are at the table. And we did get signed into law, this act. And so I think that is something that we ought to be raising up and bringing up more and more. It's critical that in our disaster response, we consider women and girls. In our post-conflict recovery, we have to ensure that women and girls are at top of mind, particularly when disasters begin. 1 in 3 women have experienced physical or sexual violence during their lifetime. I mean, 35% practically of women and girls. That is an atrocious number for our world. And how do we shrink it? Studies and research are hard-pressed to find one silver bullet. There's not one answer. There's not one this is very complex. It's very difficult. There are very few specific interventions that have already proven to reduce instances of violence, but yet we know we have to continue to improve on educating girls and women, access to health care. Ami knows that as a physician, knows that far better than I do, although I'm on the health subcommittee, and empowering women to be financially independent. Representative Frankel and I also co-authored, and I'm very proud to say it passed by voice vote yesterday out of Foreign Affairs Committee, Keeping Girls in School Act. It's to increase access to secondary education for women and girls around the world. It's about making sure that our foreign aid resources are spent addressing the barriers, and there are 14 barriers laid out in the bill, that women and girls face in attending and staying in school. And that our foreign aid resources should be tied to this. And so I strongly encourage you to look at Keeping Girls in School Act. We do have bipartisan sponsors in the Senate. Senator Young from Indiana, Senator Murkowski from Alaska, and Senator Shaheen from New Hampshire. And so we have great hope that this will actually bolster how our foreign aid resources are focused on ensuring, because as you know better than most, girls often might be in primary school, but often they don't make it to secondary education. And yet if we can get them to complete secondary education, we know that whether it's childhood marriages, we know that violence against women, we know that women will have a more educated, and will have that stronger voice at that negotiation table. This past spring, I had the opportunity to join CARE. I don't know if there are any folks from CARE here. Yes, okay, thank you. Had the opportunity to join a CARE group and a delegation of women members of Congress to visit Guatemala. Really to learn more about what is pushing the massive migration of women and girls, quite frankly, unaccompanied girls, to our southern border. And why did we go to Guatemala? Well, in part, it's actually an incredibly growing economy. It's the largest in Central America. And yet 59% of the 16.5 million people who live in Guatemala live below the poverty level. And malnutrition is significant in Guatemala. It impacts half of all children under 5. It's the worst level of malnutrition in the Western Hemisphere. We met with young people who shared that they had considered migrating illegally because they wanted the access to the opportunities. That's why they are coming in large part, at least from Guatemala. We know that from Honduras and El Salvador, there is much more significant gang violence in those countries than there is in Guatemala. Not that there isn't some in Guatemala, but we know that it's much more significant in El Salvador and Honduras. But for so many of these young people, it is the opportunities. And we know that the journey is incredibly dangerous. We talked with them, especially for women and girls who are often by the coyotes and by those who they are traveling with, are assaulted on that journey. Many, and I have visited with the groups that take in the girls here and the children, the unaccompanied children, and the level of violence and the level of assault against girls on that horrible journey is off the charts. It is horrible. And so we have to, and I talked about this today with my German friends. I said, look, we are not in this country and in this world dealing with adequately migration. We all know it's a significant problem, not just in this country, but it's a significant issue with, because of crisis, whether it's natural disasters, whether it is because of civil wars, because of conflict. But so much of what is happening, which can also cause significant health concerns when we have this dramatic issue of migration all around the world. So we have to create a much more resilient and secure world. So I commend the report for focusing on what we could do after disaster strikes, digging deep into how the U.S. government can use its unique and advanced capacities to address specifically the areas of maternal health. Although, for the record, the U.S. is not doing very well on maternal health. We have one of the worst rates in developed countries. My state of Indiana has a horrific record on maternal health. And we in Congress, in a very bipartisan way, are digging in on issues of maternal health. And so there is so much more that we can do. The challenges we face due to disasters, emerging conflicts. I've been in many hearings involved with the Ebola outbreak, which still remains a significant outbreak in the DRC. And when you have issues of such significant conflict, our health officials have such a difficult time getting in, and we have had health officials killed going in trying to help with the outbreak of Ebola in the DRC. So we do, and I want to commend CSIS for exploring the ideas, for putting forth recommendations, for being the group that brings together, I think, the best minds to hear the stories and to learn and to make recommendations. I will tell you, it's been a wonderful bipartisan discussion that I've been appreciative to be a part of, whether it's biodefense, whether it's making sure that women and girls have a seat at the table and are, that we continue to work together to raise up women and girls around the world. It's been a wonderful journey to be a part of. And so I want to thank you all. Again, I apologize that I can't stay, but my incredibly enthusiastic senior legislative staffer, Erin McMiniman, is happy to assist with any questions that you might have. But so Keeping Girls in School Act, we need to get that across the table. Making sure that we continue to talk about the Women, Peace, and Security Act, and that we hold our officials' feet to the fire when it comes to that, and Safe from the Start Act. We could use more co-sponsors on that, and we could use more people advocating for those bills. And with that, thank you all for your work. Look forward to learning more at my next CSIS meeting. Thank you.
Thank you so much, Congresswoman Brooks. The span of your knowledge, just your ability to talk about Ebola, Afghanistan, Guatemala, and the span of legislative action is so heartening. You are really a singular voice, and we're very grateful to you for the leadership you have brought to Congress on these matters. And we're delighted that you've expanded your baseball fandom from Chicago to the District of Columbia. Have a wonderful travel.
Thanks.
Thank you so much.
Thank you.
Congressman Barra, would you like to join us? Sure. Congressman Barra is an MD, a former Chief Medical Officer, Sacramento County in California, Chair of the House Foreign Affairs Committee Subcommittee on Oversight and Investigations, which you've used to great advantage in trying to put a focus on strengthening Department of State and Foreign Service at this particular moment in time when the Foreign Service is under enormous stress and compromise in many ways. We're really grateful to you for doing that. You have been very active in your role today and also in earlier legislative roles on biodefense, on public health. Thank you so much for all the contributions that you and your staff have made to the CSIS Commission, and welcome.
Well, thank you. And if there are any questions, Erin's still here, so we can direct them over to Congresswoman Brooks' Senior Policy Advisor. Thank you for the invitation, and you can see why we're sad that Susan Brooks is leaving Congress. I mean, she's a classmate of mine. We came to Congress together, and working together in a bipartisan way doesn't get a whole lot of play in the media, but it is there, and around a shared set of common values, and the value of empowering women and girls should be a shared set of values, especially when we think about what our values are as the United States of America. When I think about, this is my 8th year on the Foreign Affairs Committee, and as a physician, I've taken a real interest in global health and how we present ourselves around the world. And an interest in some of the things that are happening in Africa. When we think about fragile states, when we think about the youth bulge in sub-Saharan Africa, and think about how do you tackle some of these complex issues and why it makes sense for us to be proactive in our investments. The investments in empowering women and girls makes a lot of sense, and here's why I think that is, and why we've been trying to push this agenda with USAID and with others. There's plenty of literature out there that says if you make those early investments in girls, and Congresswoman Brooks talked about what I think is our biggest accomplishment in Afghanistan, which is the massive investment we made in educating girls, and we've been there long enough to see the residual benefit of that, of now those girls having that education, of more women in Parliament and the legislature. But when I think about sub-Saharan Africa and why I think it's so important that we make those investments in women and girls is because of this youth bulge. And what you're seeing in sub-Saharan Africa is if you don't empower those moms, if you don't empower those girls, you will face a real challenge. And part of that is empowering their reproductive rights as well, because if you want women and girls to reach their full potential, you also have to empower them around pregnancy spacing. And you know, I think with the current administration, we've been going backwards. We have tried to you know, again, in the context of U.S. politics, push voluntary family planning, making those resources available, trying to use language that the administration can support. But you can invest millions and millions of dollars, but if you don't actually empower women to be in charge of their own bodies and empower women to adequately space those pregnancies, you're not going to get that return. And I think, you know, when I think about global health and women's health, that's an extremely important piece of it. I know one of the recommendations in my mind in terms of making, I think it was a $30 million investment, is pennies when you think about what we end up spending in the DoD and elsewhere. Because if we don't invest in those conflicts and find solutions right now, we will be dealing with those fragile states on the back end. And I think that's why this is incredibly important. I think the last thing that I would say is if all of you remember, and then we can take some questions, and Erin can come up here and join me if she wants, is, you know, if you remember Psychology 101 for those who took it in college, if you remember Abraham Maslow and Maslow's hierarchy of need, at the base is food, shelter, clothing, and then the second piece is safety and security. And if we don't address those needs, not just abroad, but also in our own nation, you know, we'll never, you know, get to higher needs. And you know, so we've got to figure out what those solutions are and how we. And look, I'm a fan of Ambassador Green over at USAID. I think he has a deep knowledge and an understanding of what's going on, and I think he gets some of that. But you know, we've got to focus on the basics: food, shelter, clothing, and that does start by empowering mothers and girls who will be future mothers. And I don't say that lightly, but I think that's how you turn some of these fragile communities around. And it doesn't take massive investment. You know, I had a chance to go to Sierra Leone a summer or two ago to kind of look at we made big investments post the Ebola crisis there to get a sense of the residuals there. But you see community savings and loan programs that are small investments, you know, teaching community how to make micro loans and, you know, keep those ledgers. And you have the ability of, with very small investments, of investing and empowering. And most of those programs are led by women. And, you know, I think that's why this, you know, I'm taking a broad definition of health, but I think, you know, health is dealing with those base needs: food, shelter, clothing, safety, and security. So I'll stop with that. I'm happy to take a couple of questions, and then I do have to run off and catch a plane to California.
Thank you. Thank you very much. Erin, you're most welcome. Really. Okay. You know, in our final report, which is coming out November 18th, the recommendation that's elaborated in Janet's paper is contained in there, which is this $30 million proposal to catalyze investments in gender-based violence and promotion of services, reproductive health, family planning, maternal health, into areas that are very dislocated, very disordered. One of the arguments that we're making is that there's a lot of capacity in our government. There's a lot of funding in our government, but it's on the sidelines of these sort of situations. So we're calling really for that additional funding to be used to reward and incentivize a select number of priority missions around the world to sort of jump in and begin doing this kind of work and then pull in those other capacities. And part of that also, as Janet's enumerated in her report, and I want to ask her to say a few words, is identifying that we need more expertise. And this is, I think, one area where you can be very instrumental in identifying at AID and at State Department and in our missions where this sort of gender-specific expertise is missing or weak, where it can be strengthened. Janet, do you want to say a word about that? Because you spent a lot of time looking at where do we have current sufficient skills to be able to move this agenda forward, and where do we need to think more creatively about getting a higher level? And this is an issue that is very much on Congressman Bera's plate.
Thank you, Steve. Thank you, Congressman Bera, and thank you for all the work you've done in really promoting these issues in reasonable, bipartisan ways as best you can, but really trying to advance this agenda, so thank you. I think these issues of capacity that Steve is raising are really critical because you have capacity in some of these areas at the key U.S. government agencies, OFDA, the State Department's Population, Refugees, Migration. You have the Global Health Bureau at USAID. So there's lots of knowledge and capacity. But how that is actually implemented in the humanitarian space is very different. You know, does the Off the Dart team have to have gender expertise? No. Sometimes they do, but capturing those complexities of disaster response really requires that, and it has to be part of what you do all the time. And there's also the issues of, you know, where is the funding? Is there funding for the women's health issues out of PRM, for example? They've really advanced the gender-based violence issues through Safe from the Start, but far less funding on the women's health issues, and what there is tends to go to the big multilateral organizations. How can we better enhance the importance of that, elevate the importance of those issues within the different agencies, pull in the expertise of the Global Health Bureau, including the POP Bureau in terms of family planning? And what does that mean for the implementing partners? You know, is there any kind of requirement for expertise for those who are going to be implementing U.S. government funded programs so that they really have the capacity to go on the ground and, as we heard earlier from Fatima, to work much more effectively with local partners. And those are issues that consistently seem to fall through the cracks. So I'd love your reaction.
There's a lot in there, so I'd say I agree. So I'm going to start broadly and then kind of narrow it in and kind of couch in how I'm thinking about it in my capacity as chair of the Oversight Subcommittee for Foreign Affairs. The president would probably take this as a compliment that he's been pretty disruptive to America's diplomacy and maybe to a lesser extent our development tools. But you know, yeah, I agree with your comment. You know, the men in our foreign service, our career foreign service officers, as well as civilian employees, they're patriots. They serve our country every day, and they represent us abroad. And you know, we should take our time to thank them because they are under severe stress. But it's also created an opportunity for us to step back and say, out of this disruption, if given an opportunity, what should our diplomatic and development tools look like in the 21st century world? And I'll couch that in our post-World War II history. I mean, there was a strategy that was sustained that wasn't Democratic or Republican. And I think we can be proud of American leadership in the 70 years post-World War II in rebuilding Europe and lifting up Japan and rebuilding and creating first world developed economies and sustainable democracies, taking South Korea and helping them go from one of the poorest nations in the world to one of the richest nations in the world. We don't have that doctrine at this point in time that is sustainable. And when we're thinking about these investments, they can't change every 4 years. We have to set goals. We have to then allocate the resources. And then I think we also have to look at our international partners. So when I travel to Japan or as South Korea, they're not recipient countries, they're donor countries now. So how do we partner with countries that have similar values to then go into conflict areas and leverage our resources all in the same direction? I do a lot in the U.S.-India space, and our conversations with the Indians as they're going from a developing economy to developed economy to hopefully taking a place with the world leading nations, they have a much older and deeper relationship with Africa. And we ought to work together to leverage resources and partner as we go into some of the African nations to think about how can we accomplish mutual goals. And again, girls and women empowerment would be one of those goals that I think is readily available and important. So that's kind of at the macro level. We should be thinking about what are 2 or 3 sustainable goals that you can get bipartisan support around, and how do we keep our own domestic politics out of that as well? And on the issue of reproductive health and family planning, I think we've gone backwards, and I think we're shooting ourselves in the foot by not proactively, and again, I search for the right language, and the language I'm using is voluntary family planning, but to not make that available is ridiculous. And so we've got to move past our domestic politics. We have to come up with a long-term sustained strategy that is not a 4-year strategy, but is something that we may not see the dividends for a decade or 2, but and I don't think we've done that adequately. I think we've got talent and resources and individuals that care about this, but we also then have to do that gap analysis, what's missing, and how do we fill that as well. So Erin from Congresswoman Brooks' office is happy now. My staff person's here as well, Colleen, so we'd be happy to try to figure that out, and if there are legislative pieces that we ought to think about introducing. And a lot of the work we're doing is, if we get through this partisan gridlock and can get to a place where we can have a different conversation, we ought to be doing that planning right now. And again, to me, I land a lot on the family planning issue. So,
may I just add a remark to what you've said? First of all, the final report of the Commission comes out November 18th, contains these 7 pretty forceful recommendations, including the ones that align with the paper Janet's just done. This is meant to be a very bipartisan effort. It's a full consensus across the Commission, and to be operational and that we can move it into legislation. And we're already talking to your staff and to others about how we take that next step and think through concretely. And we're going to be back to Erin and back to Colleen and others around that issue. You talked about things moving backwards. We very self-consciously framed this report as a reaffirmation on a bipartisan basis of reproductive health rights of women. And it's for good reason. It's because we see the damage that has been done to the gender agenda in this town, in this era, and we are trying to push back in a very deliberate and very visible way with 6 members of Congress, half Democrat, half Republican, a very mixed and influential group of 23 folks. We had Julie Gerberding was here this morning, co-chair with Kelly Ayotte, to kick things off. So I think we are in alignment. I think we're able to move forward on that ideological front to make the point that we need to reaffirm the reproductive health rights of women as a central pillar and norm of our approaches. If you have just a few more minutes, I'm going to invite a few folks to offer quick remarks or comments. Please be succinct, identify yourself. We'll bundle, say, 3 or 4 together and come back, and then we'll let you offer your closing thoughts to those. So who else would like to jump in? Just put your arm up, put your hand up, and we will come to you with a microphone. Okay, then I'm going to ask some of our experts who were with us today. Hannah, can you say a few words about, just offer a few thoughts on you and Laura were here today talking about operationalizing this agenda for delivery of health services?
Sure. Well, thank you so much. I think it's been very motivating to hear from both commission members and people about the many initiatives, health, and the broader lens to health. I would perhaps ask and call for you within these efforts to move it forward to not lose sight of the more narrow definition of reproductive health services for women and girls, so as much as to effectively address those. I think earlier today we spoke a lot about multi-sector collaboration and the need for empowering women and girls, that the acts you mentioned will really help advance in a lot of places, but ensuring that health is at the center of that. So if you can maybe speak to any efforts that are related specifically to health services.
Sure. You hold for just one moment. Fatima Imam is here from Borno State in Nigeria. Fatima, you had a chance to hear what Congressman Barra had to say, or not?
I think she was out.
What advice would you give to U.S. Congress?
I'm so sorry, I actually stepped out a bit, and but just to say that it's a privilege to be here and to be able to talk to you, and probably my acts coming from Nigeria, northeastern Nigeria, you are aware of all that we are going through, probably is just to ensure that local civil society actors, local communities are actually prioritized. However, unlike how we program without consultation, it's good that in planning and in planning and design they have been consulted, but mostly funding, ensure that funding gets to the right actors rather than focusing on international actors, but it's good we go more local to ensure sustainability and impact of projects. So thank you very much.
Laura? Laura's from the International Rescue.
Sure, just to follow on what Fatima said, I was really happy to hear your emphasis on voluntary family planning, and I think it's really essential that if we want to meet the unmet need for family planning, that funding is able to flow to all different actors, including local actors who have the best understanding of the needs on the ground. So if you can support that, it would be really great. Thank you.
I can support that.
So I think back to you.
So a couple things. One, I absolutely can support that. Two, I think one thing that I've talked to Mark Green about, and I think they're doing right, is going into countries and communities that we're trying to help and identifying the assets that are there, as opposed to coming in and saying, here's what you need to be doing, and identify the gaps in those assets, and then empower those local communities to meet their needs. And being a physician who's done global health work, I think about the Promotora model that we often use in Latin American countries, where as opposed to our health workers going in there, you're identifying leaders in those communities, giving them the resources and giving them the training, because they're going to know their communities and culture, and then empowering and building up from there. And it may be different in different communities and different in different countries based on where they are, with regards to conflict, with regards to resources. When I think about the Ebola challenge, what's happening in the DRC is entirely different than what we saw in West Africa, and we can't just address both of them the same way. We have to adapt to what's happening there, and it's not just throwing money at these challenges either, because it's providing expertise, it's partnering with the global community, but also partnering with the nonprofit sector and those community organizations. And then again, when I say we've gone backwards, we put so many strings attached to the funds that they're receiving. I mean, we can sit here and talk about the global gag rule and all of that, but that often they're just going to walk. It's easier for them just not to take our funds. And that just shoots ourselves in the foot. And again, our politics here domestically are seeping into our ability to do aid and development around the world. And that isn't a good thing, because we also then lose our influence, lose our ability to work with these partnering nations. And these are incredibly complicated challenges in terms, the 60 to 70 million displaced people around the world, the fact that food and water is going to increasingly cause displacements. I want America to be at the table with our partner nations leading this. And if we don't invest the dollars today, we're going to be spending a lot more dollars on the back end trying to address these conflicts and deal with failed states and other situations. And I guess I would close with this, that what served us well in our foreign policy agenda post-World War II was that we had a strategy that didn't change from one administration to the next, that wasn't Democratic or Republican in the Cold War, et cetera. When it comes to global health and empowering women and girls, and again, I think that's a key plank to addressing fragile states and addressing the complexity here. We've got to get to that point where we have a long-term sustained strategy, and then we attach the resources to it, and a recognition that we may not see those dividends for a generation. But, and I think that's what's frustrating right now about, where we are is, right now our foreign policy and global health agenda is kind of on this pendulum that is shifting pretty dramatically. And again, that's not a good use of resources. So we look to CSIS's guidance and the recommendations. And again, I think you have an ally in our office and Congresswoman Brooks's office. So, and certainly I think there are a lot of folks that would ally with this.
Thank you. Thank you so much. Well, the fact that we have the 6 of you, the 6 members of the House and Senate within the commission is the bulwark. That's our real ability to make things happen. And we are going to push ahead as we get this out and as we move forward. So thank you so much. Please join me in thanking Congressman Barra. So I'm going to offer just a few closing remarks, and then we'll adjourn. Special thanks again to Samantha Stroman for the really prodigious efforts over many months in pulling everything together, and all of our other colleagues, Anna Carroll, Michaela Simoneau, Sarah Allender, Zoe and Mike, Zoe Humo and Mike Randleman, our interns, the congressional staff that we rely on so extensively, and of course, all of the expert speakers who are here today on the panels, and especially those who came long distances, Fatima from Nigeria, Lisa Carty from Geneva. We heard from Laura, from Hannah, from Fatima that the local community partners are essential. We heard that that women understand their needs, and that needs to be the starting point. We heard from Carl Hoffman that we have to use our imagination and think bigger than perhaps we have up to this point, and I think that exhortation is a very welcome one. We have crafted this set of 7 recommendations that will be published November 18th. We've fashioned this with the idea around what an integrated package that will be affordable and can move through with the support on a bipartisan basis within Congress. The piece that we've been talking about today around gender-based violence and family planning and reproductive health is one of those 7 elements. We're talking about $30 million in addition to existing capacities to try and move that agenda forward in a few select places. I think this issue is very ripe. I think there's enormous interest. We've heard already how many pieces of legislative initiative are already out there. We know there's a lot of existing capacity within our government, but it's kept on the sidelines of these major crises and needs to be moved in to the inside of it. We know that implementing partners have enormous capacity. Just listening to Hannah and to Lara and others, brings and those from CARE brings forward how much expertise and capacity we have. We know we have a bipartisan consensus around this. We know that there's an escalating proof of the crisis that we face here. So I'm coming away optimistic that we can move this agenda forward. Just to give you a quick preview, the November 18th study, which will come out, the final report of the commission, will be available online. We will disseminate it widely. It's calling for restoring White House leadership. It's calling for 3 steps to be taken in terms of financing the global health security agenda for the next 10 years, creating a new challenge program at the World Bank to get countries motivated to invest in their own capacities, much higher emergency contingency funds at USAID, CDC, and at the World Bank. It's calling for new operational capacities, what we talked about today in terms of gender-based violence, reproductive health. We're calling for a crisis corps of civilian experts that can be put into insecure settings safely. Today, a lot of those experts are on the sidelines. We are talking for programs to protect immunizations from disruption in disordered settings. And we have a number of recommendations on the technology side around vaccines, therapies, around supporting CEPI, getting involved in universal flu vaccine, being much more aggressive on antimicrobial resistance, and tackling head-on what we've seen in terms of the decline of trust and confidence in vaccines, which has become a huge crisis here in this country, but even more so in many other places. So stay tuned for that. We will be very actively disseminating that report and trying to move forward legislatively up here on the Hill. Thank you all for joining us today. We're delighted that you could be with us.